हाँ। பேசலாம், நம்ம பேசலாம் அங்க கேக்கு.
Afternoon, all. Am I audible?
Yes, sir.
Yes. Sir, we'll wait for two more minutes for some people to join, sir. Now I'll give a brief introduction of like what is the today's uh, program, sir. Today's program, we have planned as a South Zone Regional Conference of IMA CGP of Tamil Nadu State Branch. This is the first time we are planning this way, and we are planning it to be conducted in a hybrid mode, that is online mode. Now we are starting now, which will be held between the first four speakers given in the introduction are going to be on online, and then we'll have the felicitations and inauguration by our esteemed guest people, which we have given in the invitation. Then it will be an offline mode at our branch, which is IMA Ramanathapuram, where our people will be attending in person. So where we have four speakers who are going to be online. So it is going to be a continuous event. Since it is for 6 hours, we have planned in such a way like 4 hours will be online, then felicitations, then we'll go for the offline mode. So it will be a continuous process. So this is a short introduction. Um, uh, so I think we have around 600 registrations. We'll wait for 2 more minutes so that some people can join before starting the events.
Okay, sir.
Good afternoon, all. So I think at 3:15 we'll start the meeting. First, I request our member of the IMA CGP state body, Dr. Rajesh sir from Salem, to give the IMA prayer. Dr. Rajesh sir.
Yes, sir. Yes, sir. Thank you, sir. Thank you for this
Yes.
opportunity, sir.
Please, sir.
So, IMA prayer. எல்லாரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி, அல்லல் செய்யும் இன்னல் நீங்க, பேராசை பிரதிபலன் அகற்றி, பிணிபோக்கும் பெரும் பணி ஆற்றுவோம்.
Thank you, Dr. Rajesh. தமிழ்ல சொன்னதுக்கு ரொம்ப நன்றி. Right. Next, I request Dr. Madan Mohan, our CGP representative, IMA TNSP branch, to give the physician prayer. Dr. Madan. Dr. Madan, are you online? Okay. Rajesh sir.
Okay, sir.
நீங்களே சொல்லிருங்க
சார். மருத்துவ பிரார்த்தனை. எஸ் சார். பிசிஷியன் பிரேயர். எல்லா வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே, உன்னை மண்டியிட்டு வணங்குகிறேன். உன்னிடமிருந்து நல்லதும் சிறந்தது எனது அடைய பிரார்த்திக்கிறேன். எனது கரங்களுக்கு திறமையை தாரும், எனது மனதிற்கு தெளிவான பார்வையை தாரும், இதயத்துக்கு இரக்கத்தையும் கனிவையும் தாரும். உனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் வண்ணம் வாழும் மக்கள் படும் பாட்டினை சிறிதளவாவது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசையையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு உன்னை சார்ந்து வேண்டுகிறேன்.
Thank you, Dr. Rajesh. Now I request our IMA CGP State Branch Chairman of Studies, Dr. Sendil, to give his welcome address. Dr. Sendil.
Yeah, thank you, sir. So it gives immense pleasure to welcome you all to the wonderful CME organized today. So to give a brief note, so this is going to be first of our zonal CMEs conferences which are going to be conducted for this year. So this is going to be the South Zone CME, which is hosted by Ramanathapuram branch and wonderfully organized by our CGP secretary, Dr. Anand sir. So this is going to be a 6-hour session, which is partly online and partly which is going to be with the speakers in the venue site itself, which is going to be a Ramanathapuram IMA branch. So I request all our members to get enlightened with all the information and knowledges shared by our esteemed speakers. So kindly stay throughout the session. And I immensely thank our IMA State Branch President, Dr. Abulasan sir, our Secretary, Dr. Karthik Prabhu sir, and all our senior members and physicians who have guided for this program for the entire year and also in the future. So with this, I give our I conclude our speech, and we will again gather around 5 to 5:30 for our felicitations from our state leaders. Thank you, sir. We will proceed with the topic.
Yes, sir. Thank you, Dr. Sendil. Thank you for the kind words. Now, I think we'll go to the first talk. So each talk is going to be with the duration of half an hour. So if anyone has any questions to be asked with the speaker, since we have 8 topics and all are different topics, it would not be wise to have the question and session at the end. So like if you all have any questions, please do post and we'll ask relevant questions. So each talk is each speaker has half an hour. So now I request our coordinator and for the coordinator for the respiratory course, Dr. Nadagopal sir, who is a very good academician, who has been coordinating our course for a long time now, to give his talk on the first topic, which is going to be inhaled medications, what, when, why, and how. Sir, Nandagopal sir. Nandagopal sir. Can you mute yourself, sir? Unmute yourselves, Dr. Nandagopal sir. Nandagopal sir, you can unmute yourself, sir. He was online, like I'll call him then.
Yeah, I'm there.
Yes.
Yeah.
Yes, sir. Sir,
Yeah.
now you can start your presentation, sir.
Host
Yes.
was not allowing me to unmute.
Yes, sir. Yes, sir. Sorry, sir. Now we have done it, sir. Thank you.
Yes, thank you. Good evening. Or I should say good afternoon. I'm not really sure. Okay.
Yes, sir.
Good afternoon, sir.
Good afternoon. Good afternoon, Dr. Senthil. Good afternoon, everyone. Thanks for this wonderful opportunity once again. Can you see the screen? I'm sharing the screen.
Yes, sir. You're not seeing the slide set, sir.
Yeah, now?
Yes, sir.
Now it is. Yeah, now it is seen.
Yes,
Sir.
yes,
Yeah.
sir.
Right. Excellent. Thank you. So thank you once again. And thanks for this wonderful opportunity to present in front of our august audience. Once again, good evening to everyone. You're here to have some knowledge on a Sunday afternoon. That's very glad. More than 300 participants are here. I'm facing some technical difficulties. In case if my slides are not visible or change is not visible, please let me know through my phone immediately so that I can correct that as soon as possible. I should not be running away with the slides when you're not able to see. So let me present my first slide. Can you see any? All of you, please let me know.
The slides are seen, sir. Please proceed, sir.
Yeah. So my slide now is saying, when are the inhalers used?
Sir.
Are you seeing that slide?
Yes,
Sometimes
same
there's
slide,
a
sir.
lag.
When are the inhalers used?
Yeah. Right. Thank you. So very simply, inhalers are getting used mostly in the treatment of asthma and COPD. Of course, there are inhaled insulins and inhalers available, nasal sprays for other diseases, but inhalers are most of the time used in treatment of asthma and COPD. So let me just ask a question upfront to all the audience. Is asthma and COPD the same disease or a similar diseases? I would emphatically say no, they are not the same diseases. Their pathophysiology is completely different. So the way we need to approach is different. Although they are the diseases of the airways, the similarities stop there. They are both causing airway inflammation and they are causing airway remodeling and airway constriction at some stage. But the way the pathophysiology is totally different for each asthma and COPD. For airway structure, all of we know right from our anatomy days, it's made up of a smooth muscle layer, blood vessels and nerves. There is a spongy layer and there is an epithelial layer, mucosal layer. So what happens in asthma? It's primarily an eosinophilic inflammation, which causes bronchospasm. So which also results in inflammation and excess mucus. So this excess mucus basically causes, along with the bronchospasm and the inflammation, which is predominantly eosinophilic, which causes the breathing difficulty, wheezing, and cough. So compared to this, chronic obstructive pulmonary disease is primarily a disease which has its not allergens, but instigators like noxious particles and gases, primarily cigarette smoking, not necessarily limited to cigarette smoking. The current guidelines clearly suggest that there are more to this than the cigarette smoking, particularly biomass particles and particulates. This biomass particulates and cigarette smoking causes lung inflammation, which is predominantly neutrophilic and macrophages, which causes oxidative stress, and there is a proteinase stress as well. So this results in the lung damage, which are two-pronged based on which is the most affected part. One on the airway and another on the parenchyma. So we need to treat them with antioxidants and antiproteases and bronchodilators, because we know that if there is an obstructive area that causes a chronic not because of eosinophils as in asthma, and there is again a thick sticky mucus which blocks up the airways rather than it's clearing the airways. So there is another mechanism in which parenchyma is affected, So air exchange is occurring in alveoli, but because of this restriction and constriction, this air becomes trapped in the alveoli, which is much again common seen in COPD compared to asthma. So the old air cannot get out and the new air cannot get in. Simply speaking, very, very layman language, this is putting it. Comes in because of narrowing in connecting airway. So there is a damaged air sac as well, and there is a much more parenchymal damage which is occurring in COPD compared to asthma. So there is a emphysematous changes, alveolar membranes breaking down, the gas exchange area coming down. So the oxygen CO2, the exchange and the alveolar capillary membranes which needs to take place gets reduced. The surface area for that keeps reducing as the COPD progresses. That's why people get into type 1 and type 2 respiratory failure based on different mechanisms. So if you ask me very simply, is it asthma or COPD? If you can have a very classical way of differentiating asthma and COPD, age, asthma, it can onset at any age. Not all people who have asthma or breathing difficulty after 40 or 45 are necessarily COPD people. So there could be asthmatics also. Late onset asthma is common. So COPD usually after 40 years, but with currently what we are seeing is even after 35 years, there are there. And nighttime awakenings, it's much more common in asthma. There are allergens and triggers. If they are present more at night, there will be more of nighttime awakenings. Whereas comparatively, the nighttime awakenings are uncommon. COPD is more of an exertional breathing difficulty rather than a resting breathing difficulty. Smoking, no, in asthma usually, or maybe not more than 10 to 20 pack years. Usually, majorly smoking, but non-smoking COPD could be there. And cough usually in episodes, and breathing difficulty and wheeze always in episodes, because the airway limitation is again episodic and reversible. The airway may be normal when not in episodes. Whereas in cough, in COPD, the cough is throughout the day and the airway limitation is progressive. It's not fully reversible. The predominant inflammatory mediators are cells are eosinophils in asthma, neutrophils in COPD. There could be a small overlap, but don't worry about the overlap. If we call classically asthma is eosinophilic, COPD is neutrophilic. Diurnal variation is again very common in asthma, uncommon in COPD. First line of treatment based on, because it's eosinophilic inflammation, it's inhaled corticosteroids, whereas in COPD, it's inhaled bronchodilators. Why inhalers are the question which we have to answer, which I'll do in next couple of minutes. Past history or family history, you can see the history of allergy, childhood asthma or family history is more common, whereas in COPD patients, it's more of a history of exposure, either in occupation or in places they stay, or it is noxious particles and gaseous mixture exposure, which results in tobacco smoking and biomass exposure. So the time course often improves spontaneously or with treatment. In asthmatics, asthma is completely reversible if it started early, and it's like the people ask cure. Cure is a difficult word to define. So, but it's completely reversible. In COPD, it's usually progressive with generally poor prognosis if they present late. Common spirometry variables. Spirometry is the diagnostic tool for asthma and COPD, because always it's not possible to differentiate between asthma and COPD with clinical history alone. Although all these clinical features are available, spirometry, one of the hallmarks of asthma is bronchodilator reversibility. Once you give a bronchodilator, it's reversible. As I said, it's an episodic reversible airway inflammation. It reverses with bronchodilators also. So in COPD, spirometry, post bronchodilator, FE1 by FEC less than 0.7. The obstruction is still irreversible in COPD. So this is the basic premise. So once we know that it's asthma and COPD, both are obstructive airway diseases, but with different inflammatory mechanisms and difference in approach to treatment. So what will be the treatment of asthma and COPD? Before going into the treatment, I'll just reignite your anatomy and physiology days. I'll just say a couple of slides I'll take. So you have to understand there is a nervous system which has both central and peripheral. peripheral nervous system has two components, somatic and autonomic. In autonomic, there is sympathetic and parasympathetic. Why suddenly I am jumping into central nervous system from respiratory system? There is a lot of underlying links. The sympathetic and parasympathetic system usually act on the same organ, but in pharmacological opposition. You need to know this once you know why we are treating asthmatics and COPDs in the way they are supposedly. So you know that sympathetic and parasympathetic system are going to act on a system. They are going to act on the airway, lung also, but they're going to act in exact pharmacological opposition. So what happens is there is a balance of sympathetic and parasympathetic system on the action in the lung and in the airway also. But due to epithelial shedding, both in asthma and COPD, the parasympathetic activity increases in the airways, which is going to cause a bronchoconstriction. So the neurotransmitter for sympathetic activity is adrenaline, whereas parasympathetic activity is acetylcholine. So receptor is beta 2 receptor for sympathetic and muscarinic receptor for parasympathetic. Excuse me. Sorry. So for sympathetic, the function is bronchodilation. Parasympathetic, the function is bronchoconstriction. They're going to act in pharmacological opposition. So they're also, parasympathetic is going to cause increased mucus secretion and decreased ciliary activity and vasodilation. Let's not go there, but just think about this. Sympathetic stimulation causes bronchodilation and parasympathetic stimulation causes bronchoconstriction. And we know that both asthma and COPD are causing bronchoconstriction. That's why resulting in obstruction. So we need something to cause bronchodilation and we need to oppose something which is causing bronchoconstriction. So when we give the medicine, we give either sympathomimetic or we give beta agonist. See, because there is a beta 2 receptor which is causing the bronchodilation, we put more beta 2 substance in the airway, which is going to cause a bronchodilation because it's going to stimulate the beta 2 receptors. Or on the contrary, what we can do is we can give something which will block the muscarinic receptors. So anti-muscarinic agents. So we may give something anti-muscarinic agents which is going to oppose the bronchoconstriction. So muscarinic is going to cause bronchoconstriction. We block the muscarinic receptors. So it is going to oppose bronchoconstriction rather by dilating the bronchus. So we have to either give beta 2 receptor antagonist or we have to do anti-muscarinic agent. So this is what is the hallmark of treatment. So let's go to the next part, is inflammation. Let's go to that later. But you remember this, that we are going to cause bronchodilation either by beta 2 stimulation or muscarinic blockade. So what are the various routes of administration for asthma and COPD drugs? Of course, we can give orally, we can give inhaled medicines, and we can give parenterally. So why bother about inhaled medicines when there is a oral medications available? It's easy to pop in, easy to take. So not much of training necessary. Why we are really bothering with meter dose inhalers and dry powder inhalers and nebulizers when the oral route is available, and if we need a faster action, injection is available, right? That is our line of thinking. That has been the line of thinking for a very long time. Which is the best route for anti-asthmatic drugs? I'm not the one who's saying this. The GINA, Global Initiative for Asthma, and GOLD, Global Initiative for Chronic Obstructive Lung Diseases, they recommend inhaled medications. These both are bodies, global bodies comprising of top pulmonologists from all the countries, which India is also participant, almost more than 160 countries. They recommend inhaled medications. Why? Why is inhaled medicines the preferred route of treatment? Very simple. Tablet aspirin, all of us must have prescribed for some patient or other. It contains either 2 milligram or 4 milligram. If it's 4 milligram, it comes in 4,000 microgram. 1 milligram equal to 1,000 micrograms. At the same time, if we give a same salbutamol as puff, 100 microgram per puff, we give 2 puffs, we give 200 micrograms. So it's almost, the oral medication is 20 times more compared to inhaled medication, or putting in the other way, 20 times less drug is required for the desired effect from inhalation route. So let's see, if we compare oral and inhaled, there is a oral larger dosage used, whereas inhaled it's smaller amount of dosage. Because it is reaching the unintended places, like once we put the tablet in the mouth and it goes to the stomach and gets absorbed from the intestines, it will go from head to foot. So there is a greater chance of side effects. There is a slower onset of action and not useful in acute symptoms, whereas oral inhaled, there is a much lesser chance of side effects because there is only intended place it goes to, and there is a much faster onset of action with useful in acute symptoms as well. It is not just in chronic symptoms, acute symptoms. The advantage of oral inhalation, if I have to reiterate, direct action in lungs, quick onset of action, smaller doses of required, minimum side effects. So these are the 4 things which are, you can go again, direct action, directly going there, quick onset, very, very small doses required, and very minimal side effects because it's reaching directly and not reaching indirectly. So you can ask whether all the 100% is reaching only the lungs. No, it is not. Only 20 to 30% is getting deposited in the lungs, and 80% is swallowed going to the stomach. But it is given in a format which cannot withstand hydrochloric acid for most of the time, which is present in the stomach. So there is very little going to get absorbed into the liver, which is going to get systemic circulation. Please remember, we are giving at least 1/10 or 1/20th or even lesser dosages when we are giving as inhaled medication. So even if it is followed, even if it is going directly to the liver, directly going to the systemic circulation, the side effects are going to be much, much, much lesser. So when it is excreted in the urine, so the amount of drug which is reaching the systemic circulation is much lesser. So any given day, the side effects with inhaled medication are much lesser compared to oral medication. So what are the inhaled drug delivery systems which are available? They're called in different technical names. The meter dose inhaler is the technical name for the inhaler. Dry powder inhaler is the commonly used companies like Rotahaler, Loopyhaler, Machaler. All this comes under the technical name of dry powder inhaler. Nebulizers, of course, we have used, all of us must have used nebulizers. And there is a new entity called breath actuated inhaler, which is taking the advantage of both the dry powder and meter dose inhalers and reducing the disadvantage of both sides. So you can add on spacer plus mask as a additional to inhaler also. So what are the factors determining the amount of drug deposition? It is depending on the device. What is the particle size of the formulation? What is the nature of the device, and how easily it is going to be used by the patient? A lot of people ask me which is the best device available in the market. I always say which the patient is able to take the best is the technique. Patient is very easy to use and the patient is able to take the best. That is the best device for that particular patient. There is no one best device for across the spectrum. For some patient, it may be MDI. For some patient, it may be MDI with spacer. For some other patient, it may be MDI with like a breath actuated inhaler. For some people else, it may be dry powder inhalers. Whichever the formulation, the patient is able to take the best, that device is the best device. So why it is very important is the particle size and the deposition matters. Ideally, it should be 1 to 5 micron size, which is getting deposited in the upper and central airways, which maximum clinical effect and subsequent absorption from the lung. Less than 1 micron, peripheral airways, there are certain formulations are available for small airways disease as such. They'll have some local effect, but they'll also have the side effect of high systemic absorption. So it is still not anywhere equivalent to oral medication. So going to the, again, classification, inhaled drug delivery system, let's go. I'll put out some of the commonly used drugs, commonly used devices as per in the market. I'm not going to desist from not putting them in by their name for the ease of understanding. So dry powder inhaler, there are 2 ways which can give dry powder inhaler. One is unit dose. That means every dose is presented as a capsule. You have to put in that device and you have to take it. Which are, there could be a dry powder inhaler, which is a multi-dose. That means all the doses are kept inside that device itself. So we can take it as and when necessary. There is no separate capsule coming along with the dry powder inhaler. We'll see. In that multi-dose itself, there are discrete and reservoir systems available, nebulizer and breath actuated inhaler. Let's go. Inhalers, everyone will know and understand each, like we all would have seen and we all would have used them also. The only thing is we need to teach the technique properly to the patient. Again, there are multiple media outlets which are available to teach the patient also. So let's go to the dry powder inhaler. The unit dose DPIs are the single capsule put. I have put the different names: Rotahaler, Revolizer, Loopyhaler, Readyhaler, MyHaler, Turbospin, MacHaler, Adhaler, Fhaler, Octahaler. Everything comes under the name of unit dose DPI technically. Whereas multi-dose DPI, discrete single pre-meter dose, SIPhaler or AccuHaler, because in both of these, it is a single doses. In single doses, the medicine is there, but it's in separate pouches. In the pouch, in the serial pouch, there will be separate doses. Whereas in both Turbohaler and Novalizer, all the medicines will be put in one container, but that container will be inside itself. That container can either be replaced or the device itself can be replaced. So that is the multi-dose DPI. So if you look at this, it's again the same: Revolizer, Rotahaler, Handyhaler, and Cyclohaler, all the variants, and multi-doses. Discrete, it's SIPhaler and AccuHaler. Reservoir, it's Novalizer and Turbohaler. So this is one company's progression from 1958, that Medihaler ISO from Riker. This is the first ever time when an inhaler was used for a medical purpose, was in 1958 in a proper format. Of course, people are using for last 200 or 300 years. If you have to go back to the history, from there, every new medication has come. It has revolutionized in combinations and multiple combinations, and it has reached a place where I'll tell you one more thing, one very important, and we can be proud in saying that நம்ம ஊர்ல இந்த டெக்னிக் பேஷண்ட் பெஸ்டா எடுக்கிறான்னு நினைச்சு நம்ம அந்த மருந்தை மட்டும் கொடுக்கலாம் அப்படின்னு நினைச்சோம்னா, அந்த பர்டிகுலர் ஃபார்முலேஷன், எதர் இட் இஸ் a DPI or an MDI or a multi-dose, it will be available in that format, whichever the patient is able to take the best. In a lot of countries, including the Western countries, the formulations are available in only particular formats, not in all formats across. For example, if I have to give tiotropium in US, I can give only as a one type of device. I cannot give as either DPI or MDI. Patient is able to take, and there are patients in US who have to take 3 different molecules from 3 different devices. They have to remember how to take all 3. That headache is not for Indian patients. So Gina and Gold, again, these global bodies recommend inhalation medications, and also they recommend assessment and regular evaluation of inhaler technique. There are 2 things which is very, very important. One is inhaler technique. Second is adherence to therapy, which will equal to best therapy outcomes. So you can also ask, what does a spacer do? Spacer is an attachment to the inhaler. It overcomes the need for coordination. There are certain people who cannot use the inhaler well, particularly in extremes of age. For them, spacer is the best way of overcoming that coordination request, because what we call as a hand-mouth coordination, when we take the inhaler, the specific amount of inhaler, when it is required, that particular moment, when you press the inhaler, the mouth has to take the deep breath in. So you cannot delay it, or you cannot take it afterwards, or you cannot take it beforehand, because the unmedicated air will go in and fill the lungs, so that there is not much of an effect of an inhaler. So this coordination needs to be there. So this coordination can be overcome by using the spacer. So spacer holds the medication for a longer period of time, providing more time for inhalation to the patient, and reduces the velocity of the plume coming out of MDA. It reduces the deposition in the throat. So it is a meter dose inhaler where it is a highly technique dependent, with requiring high level of coordination between the actuation and inhalation. Many patients, including doctors, are not able to use the PMDA or pressure meter dose inhaler correctly. On actuation, the aerosol is released at a very high speed, which directly hits the back of the throat. Poor PMDA technique results in virtually no or very less drug deposition, which is being overcome by the spacer. So the aerosol could be produced is finer and slower moving, and evaporation of propellants, and it's basically you're taking the medicine in a much better way. So who should use spacer? Patients with coordination problems, children and the elderly and those who are prescribed high dose inhaled steroids, particularly more than 1,000, even if they're able to take the inhalers in a proper way, it is better to go for a spacer because the throat deposition will be much lesser. Patient with acute asthma requiring high dose bronchodilators as substitute to nebulizers. Again, those who are prescribed anticholinergic drugs to avoid the spray particles and reaching the eyes. Sir, coordinator, sir, please let me know if I'm exceeding my time.
Sir, no problem, sir. You're audible, sir. No problem, sir.
Yeah, sir. No, I just want to know that whether I'm exceeding my time also.
Yes, sir. I'll tell you, sir. You have, sir. Actually, we planned for half an hour, sir. How long is your speech, sir? Now?
Another 5 to 7 minutes max.
Then it'll be okay, sir. Okay. Sir.
Okay, right. Thank you. So nebulizers versus inhalation. The nebulizers basically should be more often used in a hospital setting, not recommended for preventer, but there are certain patients which you have to use, which the erratic drug deposition, yes, there is a poor efficacy, high doses and chance of toxicity are higher with the thing, and it's almost all the time much higher expensive compared to inhalers, and it's time consuming, you need electricity, all this is there. Whereas it is all reduced to a great extent by using an inhaler with a spacer. So what are breath actuated inhalers? They're available in 2 formats now, but every company is now coming out with breath actuated inhalers because they are going to be the next big thing in the market. So they are basically taking the advantage of the dry powder inhaler on the MDI. So it senses the inhalation through the actuator and fire the inhaler automatically, overcomes the problem of coordination. It operates at a very low inspiratory flow rate. So this is the advantage, and this is going to revolutionize further. So the usage of nebulizers are need to be much lesser. So that is where we're coming through. So what classes of drugs are used? These are the many classes of medications which are used for asthma and COPD, both short-acting as well as long-acting medications which need to be used for asthma and COPD. You can see the list, and you can see it's very high. Like I already told you about beta-2 agonist, and I already told you about anticholinergics, right? So there are a lot of beta-2 agonists and a lot of anticholinergic medication, which can be either short-acting or long-acting. The short-acting ones are salbutamol and ipratropium, we know for a very long time, or salbutamol, levosalbutamol. The long-acting ones are now expanding more than 12 hours of action, and even now ultra-long-acting called indacaterol is available. And similarly, long-acting anticholinergics can act for more than 24 hours like tiotropium and glycopyrronium are available. So there could be combinations. As I said, that you need both bronchodilation through beta-2 stimulation and anti-muscarinic agent. So anticholinergic and beta-2 agonist can be combined, which could be either be a short-acting combination or it could be a long-acting combination. Only thing, there are a lot of irrational combinations in the market. Okay, so I haven't talked about the third component, which is an inhaled corticosteroid. So I will come to this now, right now. Okay, so the combinations have to be rationally combined. So you cannot combine a short-acting form of one drug with a long-acting form of another drug. So there will be less than ideal effect comparatively. So what does it inhaled corticosteroid do? So bronchospasm needs a bronchodilator, but the inflammation, the swelling needs a controller, which is an anti-inflammatory. So this anti-inflammatory, vis-a-vis the reliever, bronchodilators are a reliever which quickly relieve the symptoms. Anti-inflammatory are going to prevent the asthma attacks. Onset of action is going to be much faster with bronchodilators, but it's not going to be the same with controllers. It will be much slower. Duration of action, much short. For reliever, it could be longer acting also. But anti-inflammatory, because it is controlling the disease, the effect are going to be long after felt, and duration of action will be actually longer than the actual drug activity. So relievers are basically given as rescue medication. Controllers are given as regular medication. But the combinations take the best of both worlds and give a combination of both reliever and the controller. So examples of relievers, salbutamol and levosalbutamol, which is most common. Again, I know I'm using a brand name, but it is the most common to correlate for you. I'm just giving that to be taken as and when required. But these are not the only medications which need to be there. Although they have a there are combinations also with the levosalbutamol and anticholinergics. So there could be a combination. There could be a pure therapeutically form of salbutamol is levosalbutamol. Quick onset. It binds to the beta-2 receptors and causes bronchodilation, usually in management of both asthma and COPD, whereas ipratropium, it works on cholinergic tone, binds to muscarinic receptors and prevents bronchoconstriction, works on the central airways. So why we need to combine? Because they need to, one is acting on peripheral airways and one is acting on more central airways. There is a total lung coverage. So that results in better bronchodilation compared to individual drugs. But the more important or the most important drug for the asthma are going to be inhaled corticosteroids, beclomethasone, budesonide, fluticasone, cyclisonide. These are the inhaled corticosteroids. Of course, there are again anti-leukotrienes like montelukast available as oral tablets, preferred as an add-on therapy, not as a first-line therapy. So we can combine the inhaled corticosteroids with bronchodilators, which will give us a better result immediately. So it is resulting in better patient adherence. But again, you need to see what is the activity of each and every medicine and what is the duration of action for every medicine, and they have to use the combinations rationally. So there are fluticasone, budesonide, beclomethasone, cyclisonide, and mometasone available in the market as of now. So, but again, each and every medicine has its plus and minuses. In the short of time, I'm not going into this. These are the commonly used medications. The last row is methylxanthine, selective PDE4 inhibitors, and mucolytic agents are available as oral medications. But the top line, the top two rows are completely inhaled medications, combinations available. So there are plethora of combinations, plethora of medications. We always feel that we are confused on what to give. So there is a very, very easy way to remember. Just go through this analog. So there is a muscarinic receptor, there is a beta-2 receptor. We need to dilate through beta-2 receptor, or we need to block the bronchoconstriction through muscarinic receptor. And there is an effect of inhaled corticosteroid which have to act on the inflammation. So if you take the medicines which are acting on muscarinic receptors, they usually end with glycopyrronium, tiotropium, like all these medications. Whereas beta-2 receptors, you can say OL, salmeterol, formoterol, salbutamol, levosalbutamol, all that will, except for the terbutaline, most of them will end with OL. And if you take the ICS, budesonide is budesone again, cyclisonide, you can say differently, but fluticasone, beclomethasone, mometasone, all ends with ONE. So you have to combine. In asthma, the first line of treatment is ICS, going through next is LABA, and third is LAMA in case where it's very, very severe. That is the usual way. The first step is ICS, inhaled corticosteroid. Second step is LABA. Third step is LAMA, or long-acting anti-muscarinic agent. Right. When COPD, it is basically the other way around. So the long-acting anti-muscarinic agent comes first, followed by a long-acting beta agonist. Then comes the ICS in certain cases where it is specifically mentioned there is a eosinophil high numbers or there is acute exacerbations. So it is basically a bronchodilator first approach in COPD, whereas in inhaled corticosteroid first approach in asthmatics. It is so there will be usually asthmatics 90% of the time with these three steps, most asthmatics will be under control. Of course, there are severe asthmatics who need some of the newer biological agents, but I'll not go there. So in COPD, along with the inhaled medication, you need other things. Smoking cessation is mandatory. Removal of the patient from the environment which is causing him the noxious particles and gas exposure is very essential. In case where is necessary, home oxygen needs to be there. Vaccines are very important because most of the elderly people need that. Rehabilitation is very, very important. Pharmacotherapy, of course, yes, dual bronchodilators are even sometimes triple acting medicines are also needed. So this is the basic premise of treatment of asthma and COPD. So in children, again, there will be a lot of pediatricians who will need to know what are the children. So less than 4 years, it's a meter dose inhaler with spacer with face mask. 4 to 5 years, meter dose inhaler with spacer. 5 years and above, I don't personally prescribe to this. I usually start using a dry powder inhaler if they're more than 12 years older. So up to 12 years, I stick to PMDA with spacer. So the alternative is again nebulizer, which is available. I'm open to take any questions. Thank you.
Sir, thank you. Thank you for the extensive presentation, sir. And you kept the time also, sir. If there are any questions, please do raise your hands. We'll ask sir the questions.
Sir, there are few questions which are posted in the chat box.
Chat box. Yes, ma'am. Ma'am, you can ask the questions from so that.
Okay, sir. One question was on oral candida. How common is it? Second is on Sencrobreathe. Is it very as effective as the others?
Yes.
Nandakumar, sir?
Let me
Yes.
answer.
Yes, yes.
Yeah, let me answer the first question. Yes, oral candidiasis is a known side effect of inhaled corticosteroids. So that's the whenever we come across, we need to change them to a meter dose inhaler with spacer, which reduces the deposition in the throat. Number one. Number two, there is a also what we need to do is the inhaler technique needs to be right. And I personally ask the patients to take the inhaler before taking food. One, for the ease of taking that. Second, I ask them to thoroughly rinse the mouth and the throat afterwards, then take the food. So yes, as we know, even not just the oral candidiasis, even sometimes esophageal candidiasis is we can see, but these are all very rare side effects, not as common as oral candidiasis. Even oral candidiasis is not a very common side effect. That's so the idea is to reduce the deposition in the throat, rinse thoroughly after the use of inhalers, add a spacer. So with these two steps, the oral candidiasis rate will come down. Yes.
Other question which was interesting was the advantage of a DPI over MDI.
See, the advantage or disadvantage, as I told during the talk itself, it is each individual patient who is able to take it best. That's the best device for that patient. There is, I cannot stick to I am going to prescribe only DPIs or I am going to prescribe only MDIs. I let the patient decide. See, I have the advantage of being a pulmonologist, all the patients coming into me. So I teach the technique. I have an assistant who teaches the technique, who comes back and gives me the feedback that this patient is getting this technique right. So then I prescribe that device. It's as simple as that. So it is very easy to teach, and more importantly, then now there are much more available multimedia presentations on how to take each and everything. So you don't have to spend time. So previously, this used to be the large impediment for general practitioners because see, I'm going to see much lesser number of patients compared to any general practitioner. So I can afford to give that time, whereas GPs can't do that. So family physicians have to be fast enough and give that. So you can use your technician or assistant to teach that, and you can even use multimedia presentations. You can give some YouTube links. It's available. Okay. So I'm not going to say one is more advantageous over the other.
Is GINA applicable to Indian population?
Yes, very much. Yeah, there are Indians sitting in that board. It is very much applicable to Indian population.
And possibility of vocal cord cancers in long-term users of inhalers or NIBs?
Very, very rare. At least I haven't come across any patient in my practice or in my circles.
Okay.
Which could directly link that.
Okay. And is it necessary to rinse mouth even after SABA?
See, you teach the patient something as a technique. Anytime you use the inhaler, please rinse it. That is more likely to stick with the patient. Sir, in the inhaler panna neenga rinse pannunga, and the inhaler panna rinse panna vendam appdinu sonna, they'll get confused. So why confuse them? Keep it simple. Yep.
Yeah, bro. Madam, if there are any no other questions, shall we?
There are two more. Intrinsic
yes,
and extrinsic asthma.
Please ask, ma'am. Please ask.
Yeah, it differentiate intrinsic and extrinsic asthma, and the other one is the role of IG.
See, the intrinsic and extrinsic asthma principles are now not being followed in our newer guidelines. So basically, yes, theoretically they are there, but the newer guidelines compared to therapy, yeah, these are the therapy, they're all considered as same. Yes, they do come under severe asthma. but I would not like to go there and confuse people. No.
Okay.
And what is the other? IgE.
IgE, role of IgE.
Yes, IgE is a allergic mediator. So it is present in certain group of people who have asthma. As I said, the eosinophilic inflammatory mediation is there. The IgE mediation is also there. There are certain people with high IgE levels who do not respond to the regular inhaled steroids. They come under the category of severe asthmatics. Even after doing everything properly, the dosages have been escalated, the dosage technique is right, and they're avoiding allergens, they don't get better. So they need to go into the anti-IgE therapy. There are biologicals available for doing that.
So stepping up and stepping down of ICS.
Sir, stepping up and stepping down, it's basically what we need to do is we need to re-evaluate the technique, and the patient is not getting control of the current treatment. The stepping up and stepping down is done in once in 3 months as per this thing, but it can be changed as per your need or as per the patient needs. Okay, so we can double the dose. Again, if you are using budesonide, let's say we are starting at 400. The patient has been symptom free for 3 months. He is totally all right. There are symptom scores which we use to assess the control, and we also do spirometry. The patient has improved a lot. Then we can step down from 400 to 200, from 200 to 100. The least dose which is needed for the patient to get the best control, we need to give that. The minimum dose with which the patient is having the best control. So the control of asthma is much more important. Yes, with that, if the control is not there, then we need to step up.
So there's a very interesting question from a pulmonologist, Dr. Sundaramurthy. Is alternative medicine challenge to us?
It definitely. Sir is my professor, sir. Greetings to you, sir. Pranam, sir. Yeah, alternative medicine is always a challenge, because you are going to say you can control asthma, you can't cure it. Whereas the alternative medicine fellow is going to say, I'm going to cure your asthma. So there is always a challenge, right? So you're speaking the truth. He is not speaking the truth. We know that, but the patient wants to believe that they're going to get cured. What do you mean by cure? Okay, I had a very interesting conversation with one of the diabetics who said, I'm taking alternative medicine, I'm getting a cure. So I asked why, how? So previously when I used to pass urine by the tree, a lot of ants used to come. Now there are no ants, so I'm cured of diabetes. So people are still living in that era, right? So we are thinking in terms of fasting postprandial HbA1cs, and we are going into continuous glucose monitoring. He is going by the ant, by the tree. So what do you call? There's always a challenge. You cannot educate everyone.
Okay.
So they are a challenge.
When to suspect aspergillus?
Yes, when the asthma is not under control and the Ig is very high, we right now the guidelines have gone from more than 1,000 to more than 500 IgE with uncontrolled asthma, and there is a CT or X-ray picture showing central bronchiectasis. We have to suspect aspergillus.
Okay, and immunotherapy in asthma, sir?
Yes, immunotherapy for definitely both slit and skit are useful in certain subset of asthmatic patients who are highly allergic. And again, their IgE comes in role. If there is a high IgE levels, yes, they're very useful.
I think the others you have addressed, sir. The other questions.
Yes, yes, madam. Thank you, madam. As you are the right person to ask the questions on behalf of everyone, and it was an extensive discussion. Thank you very much, madam. Sir, thank you, sir. Nandagopal, sir.
Thank you. Thank you.
Sir, it was an on-time finish. So there is a slight change in madam. Actually, Supraja madam was to speak next. Now we are Neminand sir is going to give his talk, and next will be Supraja madam. Ma'am, thank you for you also for accepting the same, madam. Thank you.
No problems. Thank you.
Now I call Dr. Neminand sir to give us a talk on the ongoing recent epidemic in mumps in childhood. Sir, Neminand sir.
Yeah. Good evening.
You are able to see the screen, sir? Yes.
Yeah,
sir.
yeah, I'm able to see the screen. Am I audible?
Yes, sir. You are audible, sir. You can start, sir. Thank you, sir. Thank you.
Yeah. Friends, good evening. At the outset, I'd like to thank Dr. Abdul Hassan, Dr. Karthik Prabhu, Dr. Sendil, Dr. Anand, the dynamic presidents and chairpersons of this chapter under the IAP TNSC. My sincere thanks to Dr. Gunasekar sir, Dr. Sengutuvan, Dr. Sridhar, Dr. Khalilur Rahmat, my friend Dr. Gauri Shankar and Dr. Joseph. With these few words, I like to talk on a very, very interesting hot topic. That is the topic of the day. Friends, you do see both the pediatrician, adult physician, general practitioners. We do see lots of surge in the case of mumps. Though you may not call it as an outbreak, but there is a recent surge. So I'm going to give you world wine in a new bottle. So next slide. So the incidence of mumps has been the past for the couple of months. It's been on the rise. Particularly in our own institution, we saw around nearly 60 cases for the past 2 months, and there was a similar incidence in 2016. But unfortunately, we don't have epidemiological surveillance that's happening in our country. So, based on this, we are going to have a very interactive seminar on mumps. I like to appreciate IMA CGP for bringing this hot topic into the CGP panel. Next slide. Friends, you will agree with me, mumps is otherwise called epidemic parotitis. It's an RNA virus. There is only a single serotype, but there are multiple genotypes. That is why, because of the genotypic changes, you have an outbreak. The incidence data is poor, but seropositivity among the public, both the children and adults, is very low, done by a study in Manipal. So outbreak generally usually happens around 5 to 10 years. Humans are only the natural host. We don't have animals in the mumps disease cycle. And basically, it's a self-limiting disease of a non-suppurative type of salivary glands, both parotid and submandibular, submental. Shortened down, it's a puffy cheeks with a tender jaw. This virus has got tropism to the epithelial lining, parotid salivary gland lining, or pulmonary epithelial lining, or a uroepithelial lining. Wherever there is epithelial lining, this mumps virus has got tropism or affinity. That's why you get lots of complications. Next slide. So if you look at the presentations of mumps, whenever you say mumps, you think of parotid and mumps. Please remember, 30% of the mumps do not come with parotitis. That's an important message. So the first presentation is totally asymptomatic. If we do IgG and IgM antibodies, it will be positive. That's called asymptomatic seroconverters. Another presentation is very, very common presentation that we see in our practice, where they come to you with cough, cold, fever, diarrhea, vomiting, skin rash. Neither the doctor nor the patient knows that they have got mumps. It is a mumps without parotitis. This 30%. Among the rest 70%, classical mumps with parotitis without complication occupies 75% of that 70%. So vast majority is the classical, and the minority around 15% comes with severe symptoms with parotitis with complications. That's only minority, and rarely you do have no parotitis but complications. That's very, very tricky. You can have aseptic meningitis in mumps without parotitis. That you can prove only by doing RT-PCR and CSF. So in your day-to-day practice, when you have a child with short pyrexia without localizing signs, please think before you ink. Before you prescribe antibiotics, think 1,000 times, because vast majority of them, particularly during this rain that started now in Tamilnadu, vast majority are viral in nature. Next slide. So as I told you, 100% of the mumps do come with fever. Some of them come with mild fever, which is not recognized. And vast majority have headache. This headache is mainly because of the minimal mild meningoencephalitis that happens in all the children with mumps. And many of them come with anorexia, not taking food, nausea, vomiting, nearly 85%. And generalized body ache is mainly common to adult mumps. So, as I told you earlier, parotid swelling starts unilateral and then becomes bilateral in vast majority, 80% of the cases. Before the parotid swelling comes, like measles, we look for Koplik spots. In mumps also, if you look at the or if it's opening of the strengthened Wharton's duct, you can see a red, swollen, thickened, edematous, elevated duct. That will be a predecessor for the before the parotid swelling appears. So diagnosis mainly clinical. Please remember there is no need for laboratory investigation, mumps. And please remember, mumps can be caused by other viruses other than mumps virus. Parotid swelling. Parotid swelling is caused by Coxsackie, parainfluenza, EBV, echo, CFV, and rarely HIV virus also. HIV causes recurrent parotitis. And please remember, once you get mumps, you will not get mumps next time. It gives you a lifelong immunity. Somebody comes and tells you that I'm getting mumps every year. That means it is not mumps. Probably it is a recurrent childhood parotitis that you need to evaluate. Next slide. So if you look at the salient features, vast majority, as I told you, 30% are subclinical without parotitis, and there is no age is exempted. Anybody can get mumps. Even the doctors can get mumps. So less than 6 months, we don't get mumps because of the transplacental antibodies. Once you get in adults, the complications are severe. The complications are more in adolescent and adults. Apart from parotitis, this mumps virus can affect submandibular glands in 15% of the cases. It can affect the brain, meninges, testes, ovary, pancreas, thyroid, heart, kidney, liver, joints, lungs, conjunctiva, thrombocytopenia. It can cause. So the list is many. So this is a pan-body involvement virus. Please think beyond parotid. That's a very, very important message. Never think parotid alone. Next slide. So as I told you, spread is mainly respiratory, and the incubation period is nearly 2 weeks to 3 weeks. The primary viremia occurs in the respiratory epithelium, and the secondary viremia occurs in parotid and submandibular gland. Death is extremely rare, and it is mainly due to meningoencephalitis, which is not recognized. So usually the period of infectivity, that is, when does the child infects others? That's very, very tricky, because even before the parotid swelling, they start infecting others. That's why mumps outbreak happens in large scale. That is 7 days before the appearance of parotid swelling and 7 days after the appearance of parotid swelling. What is secondary attack rate? It is the incidence of persons who are exposed to that index case getting the percentage of persons getting the infection. In mumps, as I told you, the seroprevalence, seropositivity, seroprotection in the general public is very, very low, both in children and adults. So 85% of those patients who are exposed to the index case will get the mumps. That's why mumps outbreaks happen very fast. So if you see a child with mumps, immediately isolate the child. You can prevent the spread. But unfortunately, as I told you, it can spread even before the parotid swelling appears. Next slide. So the complications, as I told you, CNS complications tops the list. And among CNS complications, aseptic meningitis is the highest. Nearly 30% of the children with mumps get CNS infection, particularly aseptic meningitis. Most majority have, if you do CSF for all the children with mumps, many of them show pleocytosis. Many of them have headache because of this mild form of aseptic meningitis, which does not require any specific treatment. It is a self-limiting aseptic meningitis. Rarely you do get transverse myelitis. Rarely you do get transverse myelitis, facial palsy, ascending paro, polyradiculitis, and sometimes cerebellar ataxia and Guillain-Barré syndrome. Each one of these rare complications we have seen over the past 2 months in our hospital. Please remember, epidermolysis is a complication of boys and boys. There will be reduction in the volume of the disease, but infertility has not been so far appeared. So you can be very confident that these children, even if they get orchitis, they will not develop infertility. And oophorite is very rare in girls, only 4%, particularly in postpubertal girls. Rarely some of them can develop mastitis. That's a very, very important sign. Suppose the girl comes with mastitis and fever, think of a subclinical mumps. And pancreatitis to the tune of 3%, and there is no risk of diabetes. You have to be happy. And rarely you do get nephritis, but almost all children do have viruria. You can do RT-PCR in urine to say the patient has got mumps. This is a very simple test. Another simple test you can do is to do an ultrasound of the parotid. If it is swelling, if you have a doubt whether it is lymph node or a parotid swelling, you can do that and then confirm. Another bedside test you can do is to take a amylase which is elevated. It's probably mumps. And arthritis is very rare. Most of the time it is uniarticular. It's a self-limiting. Usually arthritis is associated with some form of maculopapular rash. And the most dreadful complication, particularly in young children, is deafness. So every child who comes with mumps, you have to follow them for a period of 3 to 4 weeks for the appearance of deafness. Deafness incidence, according to various books, is 0.5% to 5%. It's unilateral. If you refer them to ENT early, it is reversible. Otherwise, if you fail to recognize this, it is a permanent hearing loss. And in pregnancy, usually it causes spontaneous abortion, and it can cause aqueductal stenosis and cause congenital hydrocephalus in fetuses. And rarely it can cause endocardial fibroelastosis. So you have to be very cautious if you have a pregnant mother, particularly during outbreaks of mumps. Next slide. Next slide. Yeah. As I told you, diagnosis is mainly clinical. Look at the history of, take the history of exposure and calculate the period of incubation period 14 to 18 days and look at the clinical manifestation. Then you can say it is mumps. What about the total count? Total count is not contributory. Sometimes you get leukopenia, rarely you get relative leukocytosis, lymphocytosis. Many times you get elevated amylase, and IgM mumps, if it is present, it is positive. If it is absent, doesn't rule out mumps. That's an important point. You can take a throat swab to prove PCR for the mumps. That's an easy test, but it's a costly test. It's available only in big cities. And if you suspect meningoencephalitis, please never send a child without doing CSF. In CSF, you get pleocytosis, mostly 100 to 1,000 cells of lymphocytes. And you have a normal sugar with elevated proteins. And always you can do RT-PCR of the CSF to see for the mumps virus. And when in doubt, as I told you, you can do an ultrasound of the parotid to see whether it is parotid or a lymph node. But clinically, what you can do is you can drop a perpendicular from the external artery canal. If the swelling is dividing into two halves, anterior and posterior equally, then probably it's a parotid swelling, it's mumps. If the swelling, it is either anterior or posterior, it is probably anterior cervical adenitis or a posterior cervical adenitis. So whenever you have a child with the first day of fever, with a definite history of contact with mumps, with abdominal pain or persistent vomiting, and the counts being very high, 22,000 and poly is 83, do not prescribe antibiotics. You must know why the counts is high on day 1 of fever, because in any stress condition, like my previous speaker, in asthma, acute asthma, status asthmaticus, suddenly counts will go high. If there is a seizure, febrile seizure, suddenly total count polys will go high. If there is a persistent vomiting, suddenly total count, like what you studied in your physiology, when you in the circulating pool, in the WBCs, vast majority, 90% of them are in the bone marrow. The 10% are in the circulation. Among the 10%, 3% are in the circulating pool. That is what you see in the TCDC. And the 7% are attached to the endothelium. They are called marginalized WBC. Whenever there is a vomiting or asthma or seizures, all these marginalized attached to the endothelium are released into circulation. Suddenly, within hours, the total count will be high, polys will be high. You will think it is bacterial. please remember, vast majority of them are viral. If you repeat the counts on second day or third day, it becomes normal. Just because the counts is high in a stressful condition, do not give antibiotics. That's a very, very important message. Mumps never needs antibiotics. Mumps, you should not give steroids. Next slide. Next slide. The differential diagnosis, the commonest is the cervical. Go to the previous slide. Differential, yeah. Cervical lymphadenitis is the commonest. As I told you, go to the next slide. Differential diagnosis. Next slide. As I told you, mumps swelling will lift the lobe of the. Go to the previous slide. Differential diagnosis. Yeah, the mumps swelling, parotid swelling will lift the ear lobule, and it's very difficult to find out the border of the parotid swelling, whereas in lymph node you can find a definite border. The other differential diagnoses are very, very important, because in young children who come with fever, incessant cry, you do have infantile cortical hyperosteosis, that's called Cappi's disease. Rarely you can have osteomyelitis of the mandible, ramus of the mandible. You do have children with PUO, Sjogren syndrome, and SLE. Sometimes a condition called miculis, involving the conjunctivitis and parotitis. Rarely in sarcoidosis, and you can have parotid swelling. And there is a new entity called recurrent parotitis of childhood, which needs an evaluation. And some of the drugs can cause unilateral parotitis like chlorpromazine and methyl-dopa. Bilateral drug-induced parotitis is common with nitrofurantoin and valproic acid. Any child on valproic acid for seizures, if they develop bilateral parotitis, you have to keep in the mind drug-induced parotitis. Rarely you have bacterial suppurative parotitis by Staph aureus. How do you differentiate is that it will be severely tender, and if you press upon the parotid, by opening the mouth, you can see the pus coming out of the sentence duct. That's a simple diagnostic clue. And as I told you once again, I like to stress upon that all mumps do not have parotitis, and all parotitis are not due to mumps. Next slide. The management is very simple. Vast majority don't do anything, they will become all right. Always give education, give them counseling about danger signs and complications. If it is an adolescent boy, tell them about orchitis and pancreatitis, and no need for antivirals. Antivirals are not required in mumps. As I told you, antibiotics and steroids are contraindicated. Next slide. So coming to vaccine, Indian Academy of Pediatrics recommends MMR vaccine instead of MR vaccine, because the poor coverage of mumps in childhood leads on to shift in epidemiology, the increase in the incidence of mumps in adults and adolescent boys, where you have more complications. So whereas the government of India National Technical Advisory Committee on Immunization says disability component of mumps is not a serious public health issue. So they are not adding mumps to the MR vaccine, which is given at the government centers, and also adding mumps doubles the cost. The government is not giving. As I told you, what preventive strategy at present we got without investing cost is isolating the index patient. Ideally, you have to isolate for 9 days. For practical reasons, children will not get adhered to 9 days. So CDC recommends 5 days of isolation of a school-going child whenever from the day of parotid swelling appears. Because many of the patients ask you how long to keep the child at home. Next slide. So coming to the vaccines, as I told you, the seroconversion of a mumps in MMR vaccine, all the 3 strains is very good, 90%. But whereas the clinical efficacy is nearly only to 60 to 90%. So in spite of taking vaccination, outbreaks can happen. That's important message. It's a freeze-dried vaccine. It has to be given 0.5 ml subcutaneously. Sometimes if you give multi-dose vaccine, once you reconstitute, you have to give it within 4 hours because of the cephaloccoccal overgrowth that causes toxic shock syndrome. Rarely you do see lots of children dying in the camps when they use multi-dose vial that has been kept beyond 4 hours after constitution. So this vaccine can be concomitantly given with vaccine, particularly DPT, DT, TT. It can be given with BCG, hepatitis B, Hib, OPV, and IPV. So this can be given along with any other vaccine. Next slide. So the recommendation by Indian Academy of Pediatrics is 3 doses. The first dose at 9th month of age, second dose at 15th to 18th month of age, and third dose at 4 to 5 years of age. Whereas in Government of India, in Universal Immunization Program, we give only 2 doses of MR. First dose at 9 to 12 months MR, and second dose 16 to 24 months MR. The adverse events are very, very minimal. In 5% of the cases, you do get fever after 7 to 12 days, which does not require any treatment. Rarely, after 7 days, they do develop febrile seizures. The parents will blame it on the vaccine. Please reassure them it is not due to vaccine. It is a simple febrile seizure. And sometimes, even after vaccination, rarely you do get aseptic meningitis after 2 to 3 weeks, which is a self-limiting, no treatment is required. And rarely you do get post-vaccination transient pancreatitis, which only requires reassurance, no treatment is required. And the most important message is this vaccine virus does not spread to other contacts at the household, unlike the OPV virus. There is another important message, because some of the googly patients will come and ask you, is there an association between autism and MMR? There is no association between autism, Guillain-Barré syndrome, or IBD along with the MMR. That's a very, very important message. Next slide. So you need to take precautions in these 5 conditions when you give MMR vaccine. If there is a severe illness like LRI or AG, do not give vaccine. If the child has received immunoglobulin in the past 11 months, postpone it after 11 months. The child is known case of ITP, avoid MMR vaccine. If the patient is going to get married, you need to postpone consumption for 4 weeks. And a child with egg allergy, you need not worry about egg allergy, but only thing is you have to be prepared. In a child with egg allergy, you have to have adrenaline, hydrocortisone, oxygen, bag and mask, everything on your table, and then give the vaccine. This is all the 3 vaccines are prepared in chicken breast fibroblast. The content of chicken breast fibroblast in the vaccine is very low. Even in a patient with egg allergy, only thing is you must be prepared with all emergency kit and then give the vaccine. Contraindications, very, very important. You must remember, there are 4 in number. One is a severe allergy to previous MMR vaccine. Second is a pregnancy, is the absolute contraindication. Third is severe immunodeficiency on steroid for more than 2 weeks, or having HIV, or a congenital or an acquired immunodeficiency. And the 4th is very, very important. Some of the vials contains neomycin as an antibiotic to prevent cephaloccoccal overgrowth. If there is a neomycin allergy, you should not give MMR vaccine. Please remember, it can be given to lactating mother. Whenever you give any vaccine, you have to ask the child to sit in the clinic for 30 minutes for immediate post-vaccination reaction. If there is an anaphylaxis following any vaccine, you need to give adrenaline only 1000, 0.01 milligram or 0.01 ml per kg. It has to be given IM. Next slide. So, as I told you, prevention is very, very important. You need to take the vaccine properly, you can prevent it. The post-exposure prophylaxis to the contacts has to be given within 72 hours. Ideally, for measles, it's very good. According to the post-exposure prophylaxis, Indian Academy of Pediatrics says that moms do not have benefit of having taken the vaccine, whereas pediatric infectious disease certificate, infectious disease Peen & Cherry textbook mentioned, if you give the vaccine within 72 hours, even in moms, there will be benefit to the receiver. Catch-up vaccination, particularly in adolescents, you have to give 2 doses with a gap of 4 weeks. In outbreak, irrespective of whether they have received MMR vaccine or not, you have to give it to all. And please remember, there is no need for post-exposure immunoglobulin. And recently, you have a vaccine called MMRV, that is measles, mumps, rubella, and varicella. This vaccine should be given beyond 48 months of age, because less than 48 months, there is high risk of febrile seizure. Next slide. So with this, let me come to the last slide, carry home message. Please remember, mumps is a self-limiting viral disease in younger children. The complications are high in adolescents and adults. You have to anticipate the complication, educate every child who comes to you with complications. It's a clinically diagnosable disease, no lab test is required. And then MMR vaccine is a safe way to prevent, and I urge all the doctors to give to children who come to your outpatients. And the isolation of the index child for a period of 5 days reduces the secondary attack rate. And another important message, as per CDC, I request all the doctors who are attending this conference to take 2 doses of MMR with 4 weeks apart, because now there is a mumps outbreak and majority of the doctors do not have mumps. If you are sure that if you had mumps disease in your childhood, or if you have taken MMR vaccine, you do not take. If you are in doubt, you can take the vaccine. With that, next slide. So I once again thank Dr. Sendil, Dr. Anand, IMA CGP for giving us the opportunity to conduct this certificate course in infectious diseases. If you are interested to join, the 4th batch is going on. Next slide. You can contact us immediately. You can join the course from the next Sunday. So this course is still live. The 4th batch, 4th class is going on. I request those who are interested to join this course to join. Next slide. I like to thank you all. Thanks to Dr. Anand for the wonderful opportunity. Thanks to Dr. Sendil. Any questions, I'll be happy to answer.
Yes, sir. Thank you, sir. You are on time, sir. If there are any questions, we'll take some questions. You can raise your hands.
Any questions in the chat box, Anand?
Yes, sir. That's what I'm seeing, sir. Only one has come, sir. Now.
Yeah. Any questions, you can put it in the chat box. Dr. Anand will ask.
There's one question I was asking. I think I've asked you this question before in some other meeting. Like,
yeah, in Ramnath meeting, IMA Ramnath.
Yes, sir. Yes, sir. How long does immunity due to vaccines last? Is one now.
Actually, if you take two doses, it will have lifelong immunity.
2 doses.
Yeah.
Yes, sir. And
if you get mumps, you will get lifelong immunity without vaccine.
If you get mumps, okay, sir.
Yeah,
and,
but try to get mumps in a younger age group.
Not like some comparative, like akin to chicken pox, not to get it in the older age.
Yeah, you are right. You are right.
Sir. Yes, sir. And regarding this incidence of sensorineural hearing loss in case of mumps, I think now many people are encountering, sir. Like, what is your take on that, sir?
Yeah, I think the moment you suspect hearing loss, refer to Anand and my fellow ENT surgeons, they will take care. So only the pediatricians and general practitioners' role is to think of hearing loss and then do a simple test, and then even if the mother suspects, send them early to PNT surgeons. Preferably, if you are able to recognize early, the outcome is good. So early referral is the message.
Sir,
Why do adults get mumps? Is it because of failed vaccine? Is a question, sir.
No, adults for because even now our government, we don't give MMR vaccine. Even in the children who are now children, if they become adults also, they will not have a mumps antibodies. So only thing is in private practice we are giving MMR. And so entire community do not have mumps antibodies. So that's why whole community is at risk when on exposure to mumps.
Yes, sir. Zahir, sir,
Somebody
you
is
can ask
raising
your
their hand.
question, sir. Sir, one more
Yeah.
question is there, sir. Dr. Zahir, you can ask, sir.
Yeah. Now, Dr. Randas has asked what is the diet restriction. Please
Sir, you
remember.
can unmute.
as it-
Dr. Zahir, sir,
Yeah.
you can unmute yourselves.
Yeah, there is a question.
Zakir Hussain, sir, you unmute yourself, sir. Yeah, you can
Yes,
ask.
sir. In hyperproteinemia, are vaccines advisable?
The message is
Because it will increase the production of pancreatic secretion and then it will cause more pain, more swelling. So only these things you have to avoid. What you can do is you can ask them to put the child ask to put some lozenge in the mouth and then ask them to keep sucking. That negative pressure in the intraoral cavity will reduce the swelling and pain.
So in hypoproteinemia.
Yeah, please.
Yes,
Go ahead.
in hypoproteinemia, are vaccines advisable?
Sir, sir, please, I'm not able to.
Sir, hypoproteinemia is vaccines advisable is the question, sir.
In hypoproteinemia,
Yes.
there is
Yes,
no
yes.
contraindication. Only when there is a thrombocytopenia, vaccine is, you have to use it with caution. But in hypoproteinemia, in malnutrition, you can give the vaccine, sir.
Sorry, sir, but in hypoproteinemia, how do the antibodies form, sir?
Sir,
How do the antibodies form in hypoproteinemia is asking.
hypoproteinemia,
How do the antibodies form?
in children with immunosuppressed state or malnutrition, normally any viral vaccine, particularly live vaccines, normally the seroconversion rate is little low. So ideally, you have to give 2 doses. If possible, you can give a 3rd dose after 6 months.
Sir, should we do the antibody titer for the
Ideally,
students who
it
are going abroad?
Yeah. Some of the universities, they ask for antibody titer. Many of the universities, when they go for, particularly when they go out to countries like Canada, USA, Europe, they ask for antibody titers for mumps, particularly if they come from India. So in those conditions, you need to do antibody titer. Otherwise, if they are in doubt, they have not taken vaccine, always give 2 doses of MMR and send them.
Thank you, sir.
Thank you.
So there is a question, can we use cold compress for mumps? Is a question is there, sir.
Yeah, you can do cold compress, you can do warm compression, you can do that. No harm.
Any
But whatever
overlap
you
of
do,
mumps?
whatever you do by around 5th to 7th day, the swelling will come down. So if you do cold compress, the credit will go to cold compress. If you do hot compress, or if you do put something in the neck, some chain or something like that, it will come down. So credit will go to the gold chain.
Gold
So,
chain.
yeah. Even if you don't do anything, it will come down. So the last doctor who sees the child will get credit. Sir, நீங்க தொட்டோன்னே நல்லா ஆயிடுச்சு. If you touch the child, you became already, you are a Kairasi doctor.
Because
Any overlap of mumps, parotitis and diabetic mumps, sir? The question is there.
No, sir. Mumps parotitis, mumps you can get pancreatitis. The percentage is 3%. But there is no incidence of diabetes following mumps pancreatitis, sir.
Yes, sir. Thank you, sir. Namenan, sir.
Thank you very much. Thank you very
Yes,
much.
sir. Thank you for your
entering.
kind words, and it was an extensive discussion, sir. There are no other questions, sir. So thank you for sharing your time. I think you are in a travel to some other place for a meeting. Please do, sir.
Yeah. I'm in Salem. I'm starting from Coimbatore to going to Salem. Now
yes, sir. Yes.
I have a conference, IAP conference in Salem. Thank you. Thank you very much.
Okay, sir. Right, sir. Right. Thank you very much, sir. Thank you, sir. Thank you.
Thank you.
Okay, we'll go to the next topic. Dr. Supraja, madam, she's online. Ma'am, we can see your slides on the screen, ma'am. You can start, ma'am. Thank you.
Yes, sir. So thank you. I thank IMA for giving this wonderful opportunity for talking on pulmonary rehabilitation. So my talk will be in continuation with Dr. Nandakumar in terms of the management of patients with COPD. So as sir said, in COPD, the first line of treatment is going to be first diagnosis. Second is starting them on appropriate inhalers, which are far more superior. Sir, I'm able to hear your voice as well. Hello? Anand sir?
Yes, sir.
Illa voice கேக்குது.
Okay, sir. Sorry, ma'am.
Okay, sir. So along with inhalers, the other line of management is going to be on vaccines, which was one of the questions in the box. Yes, vaccines may play a major role in COPD. And going ahead, what happens in 15 years of practice, what we have seen is in COPD and other chronic respiratory disease, despite what we treat, patients go on to have progressive respiratory failure and end up with devices on such as oxygen and the PAP devices, the positive airway pressure devices. So is there any element where we will be able to stall the process or even slightly reverse before they go into permanent respiratory failure? In that, the pulmonary rehabilitation plays a major role. So we have started a new advanced diagnostic center in Chennai, Kodambakkam, with special emphasis on pulmonary rehabilitation. My topic is going to be on what is chronic respiratory disease. I'm just not going to isolate myself only to COPD, but asthma, COPD, and the multitude of other respiratory diseases which are on the boom. And I'm sure with all of us after COVID, the surge in respiratory cases is quite high. All of us are experiencing a viral flu even in April, and most of our patients, elderly, are going on to the ICUs because they are becoming hypoxic. And what can be done in terms of what is pulmonary rehabilitation and what can be done and what we are doing in our center. So if you look at the spectrum of respiratory diseases, I do agree that the topping the list is going to be cardiac and diabetes for all of us who are practicing. The third comes our respiratory disease. In respiratory, in 2022, there was a paper by Sharma et al. Which said that asthma contributes to around 30% of our respiratory diseases, and COPD contributes to around 16%. And TB, bronchiectasis, and respiratory infections, both upper respiratory and lower respiratory, that comes around 20%. Miscellaneous is around 15%. And others is going to be a combination of pleural disease, lung cancer, ILD. ILD is on the rise because we are having multiple diagnostics which are rampantly used nowadays. And post-COVID also, we are having a good pickup in case of ILD. Now, why do we have to talk about chronic respiratory disease? Because in chronic respiratory disease, 60% of the disease is because of the lifestyle, the nutrition that we are taking, the environmental, and the access to care. These contribute to 60% of the disease, whether we are going to get the disease or we are going to stay away from the disease. 30% of it is genetics. Genetics is coming up in a big way, where we are able to identify genes and diseases. And 10% is medical history, family medical history, and others. On the right side, I have a slide which is the SDG goals by the WHO, in which the third goal is now concentrating more on non-communicable diseases, of which COPD is also a major part, along with diabetes, cardiac, and cancer. Why do we have to know about chronic respiratory disease? Because these patients are going to be symptomatic most of the time. They're going to be breathless with cough, sputum, and shortness of breath. The quality of life is going to be affected, because when you're breathless, you're going to be dependent on another person, and they are breathless even on a minimal exertion. There can be a cardiac or obesity which as a comorbidity, but respiratory cases per se have a lot of symptom on minimal exertion, and they're not able to do any outdoor activity, go for a vacation or outdoor activity or attend a function, they're not able to do. The other significant thing is DALYs, which is disability adjusted life years. If we look at the number of days a person spends in and out of a hospital because of chronic respiratory disease, it's around 1,000 days, which is around 3 years of his whole lifetime. Whereas when you compare it with a cardiac disease, which is it's around 300 days, because once you fix it, then the patient is able to get back to his routine life. Whereas in respiratory, with the season change, he keeps getting in and out of the hospital. And in Tamilnadu, it is around 1,200 days per 1 lakh population we are spending in and out of hospital. So if you look at the economic burden, private institutions, the OP, the expenditure is going to be 20 to 30,000 for the patients per annum, whereas the government spends around 7,000 rupees per patient for respiratory. And the other issue is 2 people have to take a leave whenever a patient is getting admitted, the patient as well as the attender. So apart from medications, vaccinations from our end, which we can do, is there anything else that the patient can also engage in such that they don't deteriorate rapidly? Now, this is our topic of interest today. So I have divided into 4 groups, which is group 1, 2, 3, and 4 of COPD, where initially when the patient is not that very symptomatic, if you start increasing your physical activity, eat a nutritious diet and avoid triggers, then their lung function can be maintained. And if they are having a smoking habit, along with peers, they can start going to a smoking cessation like the AA and help themselves. Now, along with smoking, there are so many other things which have come in, like vape and other inhalation drugs which have come in, which are also producing a lot of respiratory issues. And in group 3, if you can start getting them into basic breathing exercises, then it will help us to open up the alveoli. As Sir was telling, in the pathophysiology, there's going to be a destruction of the alveoli along with increased secretions. So whichever alveoli is damaged will not be able to help in oxygenation, but the rest of the alveoli which are there, we have around 480 million alveoli in our lungs. So if you can activate the rest of the lung, then your oxygenation will be much better. And we can start them on pulmonary rehabilitation at this point in time. And of course, along with medications and vaccinations. This cannot be a standalone therapy. This will be an add-on therapy with the standard of care. So what is pulmonary rehabilitation? Why are we talking about this of late? So we introduced a concept in our center as a 4P concept, where P1 is the preventive, where we diagnose the patient with spirometry, we give them the appropriate medications and the vaccinations and prevent them from getting recurrent hospitalization. Number 2, we are also doing studies on genetics, metabolomics, proteomics as to why somebody who smokes gets a disease, whereas somebody who doesn't smoke does not develop COPD. There's much more. As I said, there is a 30% involvement of other factors inside the body, which are unique signatures for each patient, whether they have the disease or do not present the disease. Number 3 is participative in terms of breathing exercises, targeted therapy, diet, and detox. And 4th is whether we will be able to predict who gets the disease in future with their profiling in terms of their lung function, the genetics, their ability to do exercise, and their body's response to exercises. With that, whether we will be able to project into the future how their lung function curve is going to be. Now, coming on to pulmonary rehabilitation, that is our P3 in our concept. So it's a evidence-based multidisciplinary team in patients with chronic respiratory disease. Now, what do we do here? We try to reduce the symptoms of breathlessness, improve their functional status, and reduce the healthcare cost, because these patients, after a point, it will be initially once a year admission, then it becomes twice a year. So it becomes too much of a burden for the family as well as the healthcare. We know that India's aging has now, the age limit has now gone to 72 years. So imagine if 30% of patients with respiratory issues are having asthma or COPD, if they are going to age along with a significant burden of the disease, it's going to produce a huge burden on the healthcare system. When it comes to COPD, what happens is breathlessness is the most common presentation, whether it's asthma, COPD, or interstitial lung disease. So it produces a significant limitation of work. Now that in turn will reduce your alveolar ventilation, because the patient is going to be lying down most of the time or resting. So his alveoli is going to collapse, and then it increases your ventilation perfusion mismatch. Now when that happens, the oxygen supply to the body, the rest of the body, the skeletal muscle system is going to reduce. And once the oxygen reduces, he develops a skeletal muscle dysfunction. Now that further reduces his activity. So this goes in as a continuous vicious cycle, and the patients start deteriorating slowly. Now, all of us in our practice would have seen that patients are slowly becoming hypoxic, then they go on to the BiPAP or the CPAP devices. So that is the stage where the downhill starts happening. So if we are to act, we have to act well in advance. Now, coming on to why the muscle deconditioning happens, there is a defect in the alveolar ventilation and diffusion. You have a reduced aerobic enzyme activity. The patient starts going into anaerobic cycle. So there is a sedentary lifestyle and there's a multiple comorbidities. Now, because of the anaerobic cycle, there's an increase in the inflammatory processes or the markers which are released, and that will result in lactic acid building up. Now, how can we improve this deconditioning? Is through reconditioning the muscles, where we are able to do structural alterations in muscles which are favoring aerobic metabolism. So you stimulate special groups of muscles which are called the type 2 muscles. Then you reduce your hyperinflation through breathing techniques, and you start desensitizing the patients to dyspnea, how to cope up with their breathlessness. If they are breathless from moving on to the bedroom to the toilet or even taking bath, if they are breathless, so you help them to first give them oxygen, then second give them something like a hand fan so that they are able to have some air on the face so that their breathlessness starts reducing, and teach them breathing techniques which will help them to like pursed lip breathing, which will help them to breathe better. So this way they will be able to cope up and rather not get very worked up with their breathlessness. So when it comes to pulmonary rehabilitation, we need to first understand what is the patient's condition. We have to tell them what is the importance of rehabilitation and what are their goals. So when patients come in, they start expecting that they go back into their previous state of life where they're completely active, they can stop their medications, they can start doing whatever they want, they can start eating whatever they want. Now we need to make them clear that here we are able to stay in the same place, if possible, to improve their quality of life and reduce their breathlessness. So we won't be able to go back or reverse the whole medical process which has already set in. And thus their expectations should also be realistic and met. And then we go on to medical assessment. Then how do we give an exercise prescription and address all their questions. So this is our team here at Medway Institute of Pulmonology, where it will comprise of the physicians who will ultimately overlook the whole thing. As I said, the standard of care remains the primary treatment for COPD. So pharmacological management, oxygen prescription, all that will happen. The physiotherapist will be guiding them with how much of exercise they can do. Now, all of us know that a lot of people start going to gym. Some of them had sustained a cardiac attack and then they drop dead. Now, imagine in our patients, if we suddenly put them through a lot of exercises, then there can be a cardiac component which was not noticed. Suddenly the patient can develop a cardiac issue. So we will have to carefully assess all these patients and then give them an exercise prescription as to, based on their cardiac and respiratory condition, how much of exercise they can do. And inspiratory muscle training, all that the therapist will give. We have a coordinator who will basically talk to multiple physicians and understand, because we get referrals from other doctors, allocate individuals so that there is a smooth flow which is happening inside the department. We also have respiratory therapists who will teach them in airway clearance and bronchial hygiene, because in patients with bronchiectasis, there's going to be a lot of secretions. So we need to teach them. So along with medications, these are simple things which will help the patients to clear their airway and be symptom free. Because they, in case of bronchiectasis, they're going to have commensal bugs. Sometimes they are multi-drug resistant bugs. So these, we won't know whether it is a colonizer or is it going to be an infection. So we'll have to teach them bronchial hygiene so that they keep clearing their airway. Then we have trained respiratory nurses who will look at the device techniques. It is very, as Nanda Kumar sir said, it's very, very important that giving an inhaler is first point. Checking how they take is another point, which is very, very important. Otherwise, we'll keep stepping up on the medications. Then we have a dietitian who guides them on what to eat. If there's a nutritional deficiency, we replenish that along with giving exercises, because if they're deficient in iron, if they're deficient in magnesium or in calcium, then if you put them through a lot of exercises or vitamin B12 and vitamin D, they're going to get fatigued. So we address all these issues. Then we have a psychologist, because a lot of patients, either they're exposed to smoking, active or passive, or there is an environmental exposure. And these patients with chronic disease, they're going to go into a psychological depression. So we put them through the psychologist to help them to understand, that this is going to be chronic. They need to accept it. Along with coping up mechanisms, we will teach them to keep them mentally alert and healthy. In our center, we also have a Ayurveda physician. The reason here is we are trying to see if we can incorporate certain techniques which will help our patients to improve, rather than negating it as something as unknown. So we are also a research institute, so we test their drugs for the chemical composition so that we don't overdose them. And also we are incorporating the concept of detox. The skin being the largest organ helps us in detoxifying the technique. So based on each patient's constitution, we are able to do this. So as I said, patients' goals should be realistic, like independent mobility or go for work or get relieved from depression. These are realistic goals which we can address. And patients' expectations from the program should also be addressed. Now, what are the components in a pulmonary rehabilitation? So we'll have our physical exercise, smoking cessation. In ours, we have the Ayurvedic detox alone, yoga and meditation. We regulate their body weight. Sometimes patients can be very lean, so we help them to attain a good nutrition. And sometimes if they are on the overweight side, based on their body composition and multiple comorbidities, we help them to reduce on the fat part of it. And we give them educational and risk factors and lifestyle modification, nutritional advice, psychological support. So when you do all this, we are able to reduce their breathlessness, reclaim their health, achieve their short and long-term goals, because they need to understand that if they come in for 1 month, the results are going to take longer time. It's going to be a way of life for them forever. And we are showing them the way, how much of exercise they can do and what is good nutrition and what are the standard of care medications that they should be taking. So in a package, we are trying to show them in 6 weeks time how they can improve their life. And they sometimes when they're very young, they can return to a very fulfilling life and be able to do their daily activity. So this is the process where we follow. Step 1, we enroll them. Second is we identify whether it is going to be a home-based or it's going to be a hospital-based or a center-based exercise. And then we find out individualized action plans we will start giving them. And then based on their lung function capacity and their cardiac status, we will give them exercise protocols, what is suiting to them. So coming on to medical assessment, apart from identifying the disease, diagnosing it, we have a core program assessment where we will find out how much of exercise they're able to do, because there can be limitation in terms of arthritis for the hands, hip. We have a lot of patients who are above 60 who come in for the rehab. So whether how much of exercise they can do, how much of weights they can lift, and the endurance, how long they can do it. And balance we do check, because a lot of patients have difficulty in walking in a straight line. So that is why that's another reason where they tend to fall, apart from the other medical conditions which can be there. And what are the activities of daily living, how much activity they're able to do, walk out, go outside to the market, or whether it's limited within the house. Their symptom scale in terms of dyspnea, like Boggs dyspnea scale, or the chronic CAT scoring that we will do, and fatigue, because sometimes the breathlessness or the limitation is because of fatigue, leg muscle cramps which are developing. And what is the current quality of life? So we have multiple questionnaires for that. Along with that, we do the anxiety and depression. We have the Hamilton scores, cognition, nutritional status, smoking status, and how many exacerbations they've had in the last 1 year. Here, exacerbation is not just admissions. Even if they are resorting to steroids, taking up of steroids 1 to 2 times in a year is also an exacerbation. That history also we taken. And we identify whether the patient is knowledgeable about their disease and they are willing to participate. So this is a case scenario which we are discussing here. As I told you, the breathlessness questionnaires which we follow here are MMRC, the CAT score, the chronic respiratory questionnaires, and the perceived rate of exertion questionnaires which we follow. For activities of daily living, we use the Barthel index. For anxiety, we have the Hamilton anxiety and the Hamilton depression score. And we measure their basic assessment like height, weight, BMI, their heart rate, the blood pressure, the oxygenation at rest and on exertion, how much it is, and the respiratory rate. So one pattern which we strongly look into is how much of respiratory rate we are able to reduce at the end of 6 weeks. For example, if they are breathing at 28, which is tachypnea, whether we are able to come down to at least 18 to 20 at their resting respiratory rate. Now, when that happens, there's a profound impact on your circadian rhythm in terms of heart rate coming down, your pressures coming down, and the patient is also not very anxious and irritable all the time. This is the lung function which we are checking. So as sir said, this is spirometry value. The FEV1 is the amount of air which we are able to blow out in 1 second. So normally it should be around 80%. In this example which I have quoted here, this patient is having it around 26% of FEV1 and 21% of forced vital capacity, the total amount of air that he is able to expel out. So this is a case of a restrictive lung disease which we are looking at. And the other thing which we are seeing is the DLCO, how much of oxygen is able to go from the lungs into the blood vessel. In his case, this is actually a 48-year-old male who's a post-COVID who came in for rehabilitation. Look at the percentage of oxygen transfer. It's only 20%. So even though his monitoring saturation is 90 on room air, he drastically reduces because the diffusion capacity is considerably reduced. This is another patient where I'm showing you on the balance. So if you ask them to walk on a straight line along the side, you notice that she is going in a perpendicular direction and is unable to walk straight. So these are simple things because these patients, when they start walking at home, they can have a fall history and injure other parts. So coming on to the other assessment which we do, we call this as the cardiopulmonary exercise testing, where this gentleman is doing it on a treadmill. So we look at the dynamic parameters of your oxygen, your heart rate, and your ECG will also show whether there is any ECG changes. The other which we are starting here is the ergo couch, which is in case patients are not able to walk, then we will make them lie down on the couch and ask them to do the exercise. So this way we will be able to identify how much of exercise we can give them. For example, here we are actually measuring their VO2 max. VO2 max is at what point the oxygen consumption is going from your aerobic to your anaerobic. That is a cycle where the patient starts falling very, very tired. So in our center, for all the patients who are having respiratory issues, we notice that the VO2 max is around 10 to 12 ml per kg per minute, which is very, very low. Less than 15 is a very low index. And because it is so low, and based on the other parameters, we then give them the exercise prescription. So settings in our center, we do it in our pulmonary rehabilitation center, which is around 1,500 square feet space, where they come in and do the exercise. Our action plan starts with, after the initial assessment, then we will give them prescribed physiotherapy exercises. In yoga, we concentrate only on breathing techniques. So physiotherapy will help you to strengthen your muscles and improve your endurance, especially your pectoralis, your diaphragm, your chest, and your quadriceps muscles. Yoga will help you to reduce your dynamic hyperinflation. That is your breathing techniques. Ability to hold your breath, breathe in and breathe out. Ayurveda, we do only a detox, which if the patient is fit, if they're on oxygen, we do not give them. If they're not on oxygen, an Ayurvedic detox we give. And psychological counseling and nutritional counseling, where we document a food log. Every week, we document what they're eating and how much quantity they're able to eat. So that way, a lot of respiratory patients have gastric issues. So the acid reflux itself will produce a significant amount of breathlessness. So when we address their nutrition, we also take care that their acidity issues are taken care, so that the symptomatically much better. So the exercise components are such. On the left, I have put a chart where we are able to see this is week 1, the warm-up exercises, where they will be rolling their arms, neck, trunk. In cardio, because these are patients, it's going to be very simple, such as sit to stand, marching exercises, step ups, cycling, walking, or treadmill exercises. We slowly start with them. Usually the treadmill and everything, we go only in the 5th or 6th week, because it takes them some time to start developing that amount of energy to even walk continuously for 2 to 3 minutes on a treadmill. Then strength training, we do bicep curls, wall push-ups, chest pecs, shoulder press. So these are with simple dumbbells which we do. So the top one, the person is doing a shoulder press, and here it is a lateral raise. So these are simple exercises which, done on multiple repetitions, will help the patients to gain the strength and endurance. So this is for your chest press. Very simple weights. This is a multi-gym where it is around 5 kg is the starting weight that we use. And this is for the leg, mainly your quadriceps. So any activity, the physical activity when you have to walk, unless the quadriceps is strengthened, the patient will not be able to walk without breathlessness. We also have a virtual reality where we are able to tell the patient how much. Here we are able to see how much of rotation or the angulation that the patient is able to do. The VR monitors it, because being an elderly gentleman, their rotational movements reduces. And the other virtual reality is where we are improving the truncal mobility, where they will watch into the device and they start moving forward. This gentleman was not able to bend forwards, but when they put the VR, the visual restriction is very much reduced, whereby they are able to move forward, bend down, and do their physical activity. So finally, we'll finish with cool down exercises. So this takes us around 1 hour per day for each patient, 1:1 with a therapist and a patient. So over the next 6 weeks, if you look at this, if the baseline, the blue line represents oxygen on room air, which was 92. Now, if we made him walk for around a minute, his saturation dropped down to 78. Imagine this is a 48-year-old male who is a post-COVID. He is a paramedical person who is an actively working person. His saturation was dropping to 78, and at rest, after 2 minutes, it was improving to 93. This gentleman also had multiple admissions, around 5 to 6 admissions in the last year, because of which he was being planned for lung transplant. And before the transplant, he was referred to us. So look at it, at the end of 6 weeks, his baseline oxygen has improved from 92 to 94. His oxygenation after exercise is 91. And at rest, after resting, is around 95. So what we notice is that when you do exercise, a lot of alveoli opens up, so the circulation improves, thereby improving your oxygenation. So if you look at the exercises which we do around cardio exercises, which starts with repetitions of 5, and it goes up to just a minute. Meeting please meeting. So cardio exercises which we do, which will, from the baseline, if you look at it, the number of repetitions which this patient has done has gone up to 35 reps, in terms of whether dumbbells or the sit-ups he is able to increase. And the duration also is increasing from 5 minutes to 40 minutes, which the patient initially was not able to do, has now increased it. Now, coming on to strength exercises, again, the repetitions have slowly increased and the weights have also slowly increased. This weights is on the multi-gym, which is increasing. So when we looked at the outcomes, at the end of 6 weeks, we had a good improvement, like in the pre-rehab lung function to the post-rehab function. There was a 120 ml improvement in FEV1. We have to also take into consideration the medicines were optimized, the patient was given a good nutrition. So it's a combined result rather than just putting it only on the medicines or on exercise. And coming on to the other question is in terms of patient's perception, like breathlessness, the breathlessness scores were starting to reduce and the ADLs were improving and the anxiety and depression was reducing. So how do you, when do you think about rehab? If your patient is going from stage 2 to stage 3 of COPD, where they are becoming more breathless, having recurrent, even requirement of steroids indicates exacerbation. That is a case when you will slowly tell them, let's please start enrolling yourself in some exercise. When their oxygenation is good, they don't need a center. All that they have to do is either go for a physical exercise for 45 minutes or breathing exercises. But once they start getting dependent on multiple increasing dose of medications, admissions, exacerbations, oxygen dependency, then you will have to refer them, initiate them on the program, and then maintain them on the program. When do not do a pulmonary rehabilitation is whenever there is a cardiac complication, such as angina pectoris, or there is a decompensated congestive heart failure, cor pulmonale, severe cognitive deficits, we do not do. And in terms of nutrition, why, and lifestyle, patients have to understand that it's not just the doctor who actually helps you in the cure. It's a participative journey of both the patient and the doctor. Along with our medications and nutrition and their lifestyle is going to make a huge impact. So they have to maintain their eating habits, their weight management, their smoking cessation, their stress, and their sleep. So when we look at the benefits, survival benefits are much better. We do realize that none of our patients, if they do not have a cardiac complication, they do not die. They suffer, but their agony is prolonged, and we help them every time by getting them out of the ICU. So we will be able to give them a good quality of life by giving them such pulmonary rehabilitation. A lot of patients ask, this help us prevent admissions at all? I wouldn't say we won't stop admissions, because there are multiple things, viral infections, there are so many things which can worsen a patient's condition. But if the patient gets admitted, the number of days that he stays in the hospital or in the ICU drastically reduces, and the ability to jump back into or regain their health is far significant. Because patients whom we have put them on rehab have also got admitted because of the weather change or because of the devices conking off. But we realize that they are able to come out of the ICU, maybe from 6 days, they are able to come out in 2 days. And from the admission of 6 to 7 days, they're able to come out in around 3 to 4 days. So that is a huge impact on the cost for them and also on the health for them. So what is the value proposition that we are giving to the patient because of rehab or because of our center is error-proof treatment because of the advanced diagnostics and the proper treatment, and cost saved to the future. That is the most important thing, because every admission, they save around 1 to 1.5 lakhs, which is a huge amount of money for anybody. And the number of days that they're going in and out of the ICU or the hospitals is very much saved. They're able to go back into routine lifestyle. There's a targeted therapy, based on the body composition and the reception of which all drugs they are suiting, which drugs do not suit them. And we can integrate with allied medicines to take certain things which are important. Like, for example, in our center, we have the yoga master who also gives us Varma therapy for pain. So I'm able to come down on my number of medicines for pain, especially my Prigaba usage has come down drastically because there's a good pain relief and the patients are able to sleep. So I'm able to cut down on their sleeping pills as well as their painkillers. So I choose and pick and choose what I want so that the patient gets the maximum benefit and we are able to come down on the medications and thereby improve their muscle strength and their relief system. So my takeaway message is going to be, identify your patients. If they're going to develop into chronic respiratory disease, identify them. And if they are starting to deteriorate, do an early referral, improve their quality life, and improve the health for all. Thank you, and I'm ready for taking questions.
Madam, thank you, madam. Thank you.
Yes, sir.
Thank you for
Hopefully I
a
have
nice
stuck to
talk,
the
madam.
time. I didn't see the timing. I'm sorry.
I think there are any questions. We'll go for questions, madam.
Yeah, there's a person,
Ma'am, I'm
Dr.
audible?
Zakir, please, sir. Dr. Zakir is raising his hands. Yes, sir.
Yeah. Sir, Dr. Zahid, sir, can ask a question, sir? Dr. Zahid, sir, you can unmute yourself and ask the question, sir. Sir, you can unmute yourself, sir.
Yes, yes, ma'am. Any special advices to people moving to hill stations?
If they're relocating to hill stations, sir.
Relocating or just a visit?
If they are healthy individuals, then if they're going above 4,000 or 5,000 feet, then they need to be a little cautious on developing a high altitude pulmonary edema. If that is the case, we can give them Diamox as a preventive drug. We have to start it 48 hours before. And if they already had an episode of high altitude pulmonary edema, this can come in any age, sir. Young age or elderly, it can come. So if that is the case, we give them acetazolamide 2 days before, and until they come back to base camp, like they ascend and then they come back to base camp, we treat them with that. But if they are moving only to relocating to hill stations, usually after some time they will adapt, and in fact the high altitude hypoxia will actually produce polycythemia. The body will slowly take care of it and they will be able to do well.
Any athletes, any special advices to athletes going to hill stations?
So athletes, the performance will reduce when they go into high altitude. Normally, even like for example in cricketing and all, if you see that if the humidity changes, if the temperature changes, the body's performance will go down. So the weather and temperature makes a huge difference. So they need to perform or increase their duration, like the endurance trainings, they have to be much more by 15 to 20%, they have to increase it when they are doing it on a level ground.
Yes, the doping, that is the athletes doping. With training in high altitudes and then come to plains for the actual race, athletic race.
So if they're coming from high altitude to level ground, nothing happens. Only when they go from level ground to high altitude, they'll have issues.
But in high altitudes, polycythemia is there. There is RBC, their own RBCs increase, and that blood is saved. And when they come to plains, their own blood is
if you're asking whether the circulation is going to be affected because of coming down and the temperature, I mean, the oxygen is better. Is that the question, sir?
No. There is a habit among the athletes. They go to the higher from the plains. They go to the higher altitudes, train themselves. Then their participation, their RBCs increase. Their own RBCs increase, and they come to the plains and dope their own RBCs with the blood, and they participate in the event.
It is a natural way to improve your oxygenation. So in oxygenation, you can either recruit your alveoli or increase your hemoglobin or increase the number of RBCs or improve your stroke volume so that the cardiac system takes care of it. So there are multiple ways, or train your muscles. So in fact, in our
center, movement of the chest with the rib muscles.
I didn't get, sir. Rib muscles?
Bucket handle movement of the ribs. That should be encouraged in the females also and males also.
Yes, sir.
That should be the main thing.
Yes, sir. In athletes, in fact, we do our cardiopulmonary exercise testing, and then we tell them what is their VO2 max, and then we ask them to train accordingly. We ask them to come back and then check whether the VO2 max has improved. So once their VO2 max improves, that is the amount of oxygen the muscles are able to take for performance, then their the concentration and performance enhancement is very good.
In this body, see oxygen dissociation curve, it's plateaued in the 94.
It plateaus around PO2 of 60, so it will start plateauing.
SpO2 around 94.
Yes, sir. SpO2 is around 92. Yes.
Yes, 94.
So the arterial oxygen around 60, the monitor saturation of around 92. That's what we say.
That is our gas, ABG.
Yes.
ABG is 60. artificial gas.
Yes.
FUP is 94.
Okay. Fine.
Thank you.
Thank you, sir.
Dr. Supraja?
Yes, sir.
Dr. Sundaramurthy
One has
from
asked to
Chennai.
ask you to share the last slide on Dr. Dinagar.
Yes, sir.
He's asked whether can you share the last slide.
Yes, sir, I can share. Sir, Dr. Sundaramurthy is also asking me a question. Yes, sir.
இல்ல, you carry on. அது முடிச்சிட்டு பண்ணுவோம்.
Okay, sir. 1 second.
It was a very useful slide, last slide.
Okay, 1 second, sir.
Madam, what are the routine vaccination do you suggest for these COPD or asthmatic patients, madam?
Sir, we normally do every year flu we do, sir. And pneumonia, there are 2 vaccines for pneumonia. One is the Prevenar 13, which is once in lifetime. The other is the pneumococcal 23, the polysaccharide vaccine, which is once in 5 years. Both we will give, sir. So normally we give the PCV 13, and then 1 year later we give the PPV 23, we give it. Flu every year we give. Off late, they're also telling us that it's better to vaccinate for shingles. Varicella as well, they're asking us to vaccinate. Although the cost is prohibitively high. So 2 doses, 1 dose is around 12,000. So not many patients are in for it. But flu, we do give. So flu is around 2,200 per year. So how I convince my patient is, okay, being in the city, I have an advantage. Whether they want to pay 2,200 or they want to pay 2.5 lakhs in the ICU. So they as well take it. So pneumonia and the flu we give, sir.
Very good comparison. Very good.
In case of a patient is already on long-term immunotherapy or immunosuppressant, how the vaccine we have to, there is any interval in between the immunosuppressant and the vaccination, madam?
We don't stop immunosuppression, sir. So in case of CKD patients, or especially IgA nephropathy or the renal transplant patients, we don't stop it, sir. So all these are all live attenuated vaccines. So we do not stop, we do give. In fact, the prior to transplant patients, we give the PCV 13 beforehand, so that their immune system is much better when they before the suppression happens.
Okay, thank you.
Madam, only one question because the time is up.
Yes, sir.
In your pulmonary rehabilitation program, the outcome is better in male or female?
Depends on who participates, sir. So
no, அதுக்கு இல்ல. So உங்களுக்கு அந்த mental makeup அதெல்லாம் பார்த்தா தெரியும். Who beats, who better?
Females, because the determination and the wanting to be independent, ability to do their own activity, and at the moment I do not have smokers in females, so their adherence and response is far better. In fact, the last patient we had, as your question, a male and a female who finished. In fact, the female had a very good improvement in her DLCO from 40% to 72%.
Yeah. That's true. That's true. Thank you, Supraja. Well done. Keep it up.
Thank you, sir.
Thank you, ma'am.
Thank you, sir.
Ma'am, there's a question.
Yes, sir.
Is saturation of 90 to 94 enough for a bedridden geriatric patient, 86 female, without O2? Any specific advices to improve? CT shows very minimal pleural effusion, age-related thin plate atelectasis in lower lobes.
Okay.
Patient is on Ryle's tube.
Okay. So we will keep it like this. If the patient is a healthy patient, then the target saturation should be about 92%. If it is going to be a chronic patient, in case of a respiratory, or in this case, like a debilitated patient, then come down on your oxygen targets to 88%. So 85 to 88 should be fine. Whereas in this lady, without any underlying respiratory issue, if you are able to improve her breathing by in terms of making her sit up, not lying down completely, that produces a significant amount of atelectasis in the base of the lungs. So if you are able to make her sit up, the oxygenation will automatically improve. And also Ryle's tube feeding, preferable to keep the patient on 30 degrees or 45 degrees, because there will be a continuous micro aspiration which will keep happening, and that itself will produce recurrent respiratory issues. Yes, sir. Stop. So can I stop sharing the?
Yes, sir. Definitely. Ma'am, I think there are no more questions, ma'am. Shall we move on to the next
Yes, sir. Thank you
speaker?
so much, sir. Thank you so much for the opportunity.
Thank you, madam. Thank you for a very extensive talk on this. And it's a new topic, like anyone will be beneficial with this, ma'am. Thank you, ma'am.
Thank you.
So next speaker is Dr. Murugan Ravindran. He's assistant professor of medicine at MMC. He's going to talk on heat-related strokes. Like when we planned this meeting, it was heat stroke all the way. Now the climate has suddenly changed. But anyway, we'll proceed, sir. Murugan, sir.
Sir, good evening.
Yes.
Thanks for the introduction.
Yes,
I
sir.
hope I'm
We'll start the
audible.
slides.
I'm sorry, I have some video issues. I just realized. Okay.
Now, can you see your slides, sir?
Yes, I can.
You can start, sir.
So yes, like Anand sir was telling, these topics were decided, and we were more looking into patients last month, especially in the early April. But then now, thanks to the nature that we are getting a little bit cooler atmosphere, but still there are places such as Punjab, New Delhi, Andhra Pradesh, and even in some parts of our Tamilnadu having some heat stroke or heat exhaustion patients coming around. Sir, can I go to the next slide? Next slide, please, sir. So we have an estimated in the past, since March 1st, we had about 16,000 heat stroke patients, of which 60 had fatality. So we just thought we would go over some of the important heat-related disorders. So starting with thermoregulation, followed by the specific topics and how we manage them. Next slide, sir. So thermoregulation, as we know, it's a maintenance of, it's a physiological maintenance between the heat generation and heat loss. So that is important for a normal metabolic function. So approximately we are good. Our body is good around 37 plus or minus 0.5 degrees centigrade, except for some diurnal variations. Axillary temperature being 36 degrees centigrade, oral 37, rectal and ear temperature is around 37.5 degrees centigrade. Rectal temperature is more accurate for especially to get the core body temperature. Next slide, sir. So we know the physiology, just a glance about the physiology. So we have this preoptic nucleus in the anterior hypothalamus, correct? So that's the main thermosensor area which receives the signals through the autonomic nervous system. So the central thermoreceptors and peripheral thermoreceptors get linked with this hypothalamus and thereby relay the temperature pathway. So the central thermoreceptors are more over the viscera, spinal cord, and hypothalamus that monitors the core body temperature measurements, and the peripheral thermoreceptors over the skin, that would be for surface temperature. Now, if there is any warm environment or a very hot environment and there needs to be a temperature reduction to occur, we know that vasodilation occurs, marked diaphoresis, that is sweating, occurs through the cholinergic neurons by the sympathetic nervous system. So thereby the temperature is reduced or maintained, balanced. Whereas if we are exposed to too cold of a temperature, then there should be temperature generating mechanisms by brown adipose tissues, which favors heat production, and through some many skeletal muscles, somatic muscles through the somatic motor neurons. So there would be a process of shivering and heat production. This again is mainly by the noradrenergic neurons of the sympathetic nervous system. Next slide, sir. So we have some common heat dissipative mechanisms. So the most commonest is evaporation. This would be physics. So evaporation is being the most efficient mechanism of heat loss from our skin moisture. The other types are radiation, conduction, and convection. Radiation, again, it depends on which is the hot environment and which is the cold environment. We keep ice over our hand, the ice melts, that's because of the warmth of the hands. Conduction is nothing but here transfer of heat to a cooler object. So the heat gets dissipated to a cooler object, that is conduction. And convection is nothing but loss of heat to air current. So loss of heat to air current, that would be you have a cup of coffee, you could see the beautiful fumes. That's the loss of heat. Next slide, sir. So again, very basics. What is heat? What is temperature? Heat is nothing but energy. An energy inside a system or an object. And what is temperature? Temperature is the intensity of that energy. It could be a potential or a kinetic energy, but that is what we record in the form of temperature being recorded in thermometer. Next slide, sir. So now coming to the people who can have these issues. Not all get heat related illness in spite of heavy exposure to heat. Vulnerable groups would be children because they do not have the judgment. They'll tend to play more at sun, and that could place them in dehydration. Pregnant women, elderly individuals, persons with comorbidities, laborers who get exposed to more sun and work, police, military people, athletes, and obese people. So these are vulnerable groups for heat-related illness. Next slide, sir. So there are the individuals, there are many predisposing factors, and there are medications which push someone to heat-related disorders. So people of that we had seen, elderly people, people on beta blockers, calcium channel blockers, very commonly used for antihypertension. Those people can have vulnerable effects because of the anticholinergic effects of these medicines. Likewise, a cardiac failure patient or a person who is on diuretics with also some kind of cardiac issues or with some kind of medical issues in terms of cardiovascular system, they can be predisposed for a heat related disorder. People with cerebral injury, cerebral hemorrhage, or a hypothalamus infarct, or on psychiatric medications, disorders, or person with a status epilepticus. Likewise, in endocrine system, an uncontrolled diabetes or diabetic ketoacidosis, a person with thyroid storm or a systemic inflammatory response syndrome, those are also vulnerable. And definitely we need to rule out sepsis before we label this patient as heat stroke, because we have stress leukocytosis in a heat stroke, we have marked leukocytosis in a case of a true sepsis. So we have to rule out encephalitis, meningitis, sepsis, and enteric fever. Next slide, sir. Definitely poisoning is it could also confuse the clinical scenario. So if there could be an amphetamine overdose or any anticholinergic ingestion, a cocaine, and also a part of the medication side effects, malignant hyperthermia or neuroleptic malignant syndrome, serotonin syndrome, should be kept in our mind. Likewise, antihistamines or heterocyclic antidepressants. These heterocyclic antidepressants can affect the dopamine pathway, thereby it could impair the sweating and thereby decrease the heat loss. Likewise, excessive heat load depends upon the lack of acclimatization or severe exertion. It's been said that an exercise, a vigorous exercise in a heat stress area can increase the body temperature to 20-fold. Next slide, sir. Now, some of the medications that could place a person for heat-related disorder. NSAIDs in the form of a mild renal injury, thereby leading to dehydration, or maybe a pre-renal AKI, a dehydrated patient with NSAIDs, or anticholinergics. Like I said, it impairs the thermoregulation, decreased sweating, and thereby reduced cardiac output because of the plasma volume changes. So atropine, hyoscyamine, scopolamine could be in mind. Likewise, the H1 blockers or anti-vertigo medicines, meclizine, promethazine, those are also noted to cause a heat-related, could predispose for such disorders. Likewise, trihexyphenidyl has been frequently been noted. Topiramide, sonisamide, because of their carbonic anhydrase inhibition, they impair the sweating. Next slide, sir. Other medications such as antispasmodics, oxybutynin, sulfasenacin, those also have anticholinergic effects. Very commonly used AC inhibitors, ARB, angiotensin receptor blockers or beta blockers, that also is known to cause due to anticholinergic effects. Muscle relaxants, especially tisanidine, has been associated with this heat stroke issues. Selective serotonin reuptake, serotonin and norepinephrine reuptake inhibitors have also been noted, and especially people with ethanol congestion. We had a couple of patients with heat cramps, binge drinking, nation, heat cramps. Next slide, sir. So now moving on to the specific topics, minor complaints with this heat related disorders would be heat edema, prickly heat, also known as miliaria rubra, heat syncope, hyperventilation, tetany. Next slide, sir. And also heat cramps and heat exhaustion. So these could be easily corrected. Heat exhaustion, if caught early, we could easily reverse the pathology to physiology. But heat stroke is a real emergency if not corrected at the earliest. Next slide, sir. So starting with heat edema, what is heat edema? Mild swelling of hands, feet, and ankle. This would mimic just like a CCF or a chronic liver disease or something to do with the renals, a nephrotic syndrome. But careful history and clinical examination is at most important. What is the mechanism? It is nothing but cutaneous vasodilation, thereby the interstitial fluid gets pooled due to the heat stress. There is just a raise in antidiuretic hormone and aldosterone. For such a condition, if we are sure with the history and this clinical findings and we label him or her as a heat edema patient, do not use diuretics. It's a simple limb elevation with leg stockings is adequate enough. This will settle on its own. Next slide, sir. Next comes as the dermatological condition, prickly heat, miliaria rubra. So what is it? Maculopapular pruritic erythematous rash, especially in covered areas, clothed areas. A very characteristic symptom would be pruritus. As we can imagine, the sweat pores gets blocked by the debris from macerated stratum corneum, and thereby inflammation in the sweat ducts occur. So ducts obviously dilate, rupture, and thereby vesicles formation occur. So the treatment of choice would be, yes, antihistamine to take care of the pruritus, and a simple calamine lotion is adequate enough in addition to chlorhexidine ointment. Very simple, and also to reduce the heat exposure. Next slide, sir. Then comes heat syncope, that is exercise associated collapse. This is mainly, it follows with endurance exercise, occurs in the elderly, prolonged standing and sudden standing after a prolonged exposure to heat. So mechanism is again heat stress, that because of the stress the body volume fluid is depleted. There is a decreased vasomotor tone and peripheral vasodilation, this leading to postural hypotension. So basically the plasma volume gets decreased because of excessive sweating, vasodilation, postural hypotension, especially challenging in elderly. Again, we have to rule out if there is any cardiac issue, if there is any neurological issue, or if there is any hypoglycemia, electrolyte abnormalities, any other metabolic causes. Then with the history, we can understand this could be probably heat syncope. If it is heat syncope, a simple oral rehydration therapy and is adequate oral hydration, if required IV, and shift the person to a cool environment. Next slide, sir. Hyperventilation tetany. Hyperventilation, that is because of the respiratory hyperventilation, we know that it causes respiratory alkalosis. So a reduce in fall in PaCO2 occur. Now, because of the heat induced hyperventilation, and also because of the fall in PaCO2, the ionic calcium, circulating ionic calcium will be decreased. It would show us a pseudo hypocalcemia, but definitely there is no free circulating calcium levels, and thereby the tetany in the form of paresthesia, hypocalcemia in the form of paresthesia and carpopedal spasm occur. So this could be usually associated with the mild myalgia or a muscle compartment pain. So again, mechanism is rise in body temperature, increases the minute ventilation, that decreases the PA partial carbon dioxide, and that favors the reduction in cerebral blood flow. This is basically to reduce the heat, but this caused some electrolyte abnormalities or nutrient abnormalities. So treatment is oral rehydration and shifting to cool environment. Next slide, sir. Heat cramps. This is again commonly in the form of heat-related illness. All we have got so far is a couple of patients with heat stroke and a few heat cramps in our MMC. So with heat cramps, that is exercise-associated muscle cramps, intermittent, painful, and involuntary spasmodic contractions of skeletal muscles. This would be very different from an exercise-induced cramps. This would properly a heat cramp. Profuse, there will be history, profuse diaphoresis with, and they would have had plenty of water or some hypotonic fluids. There the sodium depletion would have occurred just with just plain distilled water. Common people who gets affected are people who work outside, roofers, firefighters, athletes, military people, and field workers, vendors, etc. Relative deficiency of sodium, potassium chloride, and the intracellular fluid level is deficient. So how would we treat it? A simple ORS solution or an frequent mineral drinks. We can also use tablets, that is sodium tablets, 650 milligrams of salt dissolved in about 1 quart, approximately a liter. So that gives about 0.1% the strength of saline solution. Next slide. Now coming to heat exhaustion. Heat exhaustion, this again, it's an thermoregulatory imbalance, maintenance of thermoregulatory control and CNS function. Here the CNS function is not altered and the thermoregulatory control is still maintained, unlike heat stroke. The core temperature is less than 40.5. Definitely it is high, but the functions are maintained. There could be a mixed water and sodium depletion in here. Common people again who gets exposed outside, laborers, athletes, elderly people. So water depletion, heat exhaustion, and salt depleted heat exhaustion has to be thought in mind. Depending upon the patient's clinical status, we have to treat him, her appropriately. So common symptoms would be headache, vertigo, ataxia, impaired judgment, malaise, dizziness, nausea, and muscle cramps in heat exhaustion. Next slide, sir. Also, they could have orthostatic hypotension for obvious reasons. There can be a persistent or sinus tachycardia. There can be an rise in hematocrit values at times, but not always. We know that among the organs, the liver gets maximum stressed out in case of high temperature. So the hepatocytes get stressed out, and so if there rise in temperature, we can see some spill of the liver enzymes. So hepatic aminotransferases are mildly elevated in a case of heat exhaustion. Some patients develop heat stroke after removal from the heat stress environment. So this person, if not treated adequately, correctly, can get into a heat stroke. Next slide, sir. So aggressive cooling of non-responders is indicative until their core temperature is 39 degrees centigrade. So from 40.5 to 38 to 39. Except in mild cases, free water deficit should be replaced slowly over 24 to 48 hours to avoid a decrease in the serum osmolality of more than 2 milliosmoles per hour. Next slide, sir. Now coming to one of the emergencies, heat stroke. This is a pure clinical condition of exclusion. It's very difficult to label this, and sometimes it is easy as well, depending upon the history. So exposure to heat stress or CNS dysfunction, exposure to heat stress with the CNS dysfunction with the core temperature of more than 40.5 degrees centigrade. So this is a triad. So this person always presents, mostly presents with severe tachypnea, different types of tachyarrhythmias, any type pattern of tachyarrhythmias, hypotension, and there can also be a wide pulse pressure. So with these features, and there are no other medical medications or no other comorbidities with that above triad, we can nail down to heat stroke. We still have to make sure we have to rule out other diagnosis of hyperthermia in the form of neuroleptic malignant syndrome, or if it could be sepsis or meningoencephalitis or serotonin syndrome, many other clinical conditions. Those all are excluded, and we have a clear history of heat exposure, and this person has a CNS dysfunction. That's why we call that as stroke, heat stroke. Then we can think of treating, cooling the person. Clinically, they present with weakness. Some people can be lucid. They will not have any symptoms, but many of them can go for weakness, dizziness, disorientation, ataxia, GI issues, and psychiatric symptoms. Next slide, sir. So heat stroke, when to a point where the person is okay in for terms of cognition, that was heat exhaustion, but then the CNS dysfunction started to occur. The temperature started to go more than 40.5. So why does that occur? The heat stroke occurs suddenly when the maintenance of adequate perfusion requires peripheral vasoconstriction to stabilize the mean arterial blood pressure. As a result, the cutaneous radiation of heat ceases. So when the radiation of heat ceases, there is no way for the heat to escape and the temperature starts to build up. Next, sir. Next slide. So with that temperature, as it starts to build up, then this person is going to have a huge problem. Now, let's say that 40.5 degree, it is getting to 42 degrees centigrade, and the person's host environment has been there for some hours, then it is very hard for us to reverse the condition, because cell injury could occur at the temperature of 42 degrees centigrade and above if left for a long period of time. So a little bit of suspicion can help us also get the diagnosis correct. Suppose we are not sure about this patient, there is an overlap of sepsis, leukocytosis, there are other CNS conditions. Immediate cooling, a simple bedspread dipped in water, place over the patient with some ice packs over the axilla, over the groin, or over the neck. That could help us understand if the condition, if the CNS dysregulation reverses. Then that could help us in the diagnosis. But eventually, we'll have to come up with other lab investigations as well as soon as possible. Now, with this heat stroke, we have two classifications. One is the classic heat stroke that commonly occurs in, also known as epidemic heat stroke, that occurs in elderly, whereas one is exertional heat stroke, that is in young patients. So in classic heat stroke, it is an old patient, probable comorbidity, probable medications in him or her, and they had an exposure to heat waves in a sedentary fashion. I had a patient 2 weeks back. She was in Vellore. She had stayed in queue for ration for her ration goods 2 hours, and then she had a fainting attack. Severe diaphoresis brought in as heat stroke. No comorbidities except that she was 70 years. So, so that's the sedentary. And probable CNS dysfunction would be there, or early changes could occur. Anhidrosis is possible. There could also be oliguria, coagulopathy, a mild lactic acidosis, and at the start of creatine kinase elevation could occur. In a case of classic heat stroke, there can be hypoglycemia or it can be normoglycemia with not much disturbances, early disturbances in the electrolytes. Whereas in an exertional heat stroke that occurs in young patient who previously was healthy, no medications, the sporadic changes would have occurred just with exercise. The presentation would be severe sweating or lack of sweating because vasoconstriction could have occurred. So lack of sweating or severe sweating. There could be a myocarditis because of the heat, or hepatic injury because of the heat. So hepatic injury, the AST, ALT, initially the AST will rise, then the AST, ALT can go more than 100 times, where CPK, MB also will start to rise because of the myocardial injury. But we shouldn't, the ECG can show various tachyarrhythmias, various patterns, or an non-specific ST T-wave changes. But we have to keep in mind, at the same time, we have to also make sure the echo is done. Acute renal failure occurs and eventually the creat starts to build up. DIC is very deadly, especially in this exertional heat stroke people and also in classic heat stroke people. That would be that has to be treated immediately with fresh frozen plasma or cryoprecipitate. And in addition to that, marked lactic acidosis, rhabdomyolysis occurs because increase in creatine kinase occurs to 4,000, 5,000. So that leads to rhabdomyolysis, again a renal injury, severe hypoglycemia, hypocalcemia, and hyperkalemia, with or without the changes in the sodium, perhaps hyponatremia also. Next slide, sir. So my slide is empty. So next slide. Investigations. Okay, so if we go over the heat stroke, actually that slide which I had disappeared, the words, but the thing is that what I mentioned in that is, the earlier we identify that it is a heat stroke, the better that we can reverse the condition. And what are the investigations? All the basic investigations we have to do in all heat related illnesses, disorders, especially CK, creatine kinase, total CPKMB, look for the urine routine, look for the RBC casts, look for myoglobin, and also run the panel for RLE, renals, liver, and electrolytes, and CBC as well. And make sure that DIC is picked much early. Go for fibrinogen, D-dimer, PT-INR coagulation profile, and be prepared to make sure that we do the right thing. So that would be the and definitely follow up the IVC diameter for taking care of the dehydration or the volume overload. And the same thing with cardiac monitoring. The cardiac monitoring is very important because we cannot say that this is purely heat related, and we cannot, maybe if there is an earlier intervention to be done, addition to cooling in terms of arrhythmia, then we need to act accordingly. But the further slides, I will just clarify that. So the next would be the immediate thing would be cooling, like I said previously, within 30 minutes. And any type of methods in the form of conduction, convection, or evaporation can be done. Next slide, sir. So in a field setting, whatever measures we can, if that person is an expert, the emergency medicine person is an expert, the ambulance guy, then he or she can immediately take measures, field measures, in the form of tepid water sponging or ice packs that is available within the ambulance. So within about 15 to 16 degrees centigrade, about 16 would be ideal to give some to make measures to reduce the temperature. In an emergency department, we have more facilities, ice waters and different approaches due to we have refrigerators, so freezers. So we can use about 1 to 5 degrees centigrade packs, cold blankets, better than blankets, very thin materials, clothes, so that it also helps in radiation, dissipation, etc., not to block the air over the patient. So again, the same thing. We have to make sure that heat stress related heat exhaustion, if not treated early, can get into a heat stroke. And also, very important, do not have to differentiate between an exertional versus an classic heat stroke, because the treatment is going to be the same: cooling, cooling, cooling. Next slide, sir. So cool first, transport second. That's how an efficient ER should, the emergency medicine team should be on the field. And whatever possible ways of immediate rapid cooling to be done has to be done immediately, and the patient to be shifted. And the cooling can occur anywhere between 10 minutes to 45 minutes to 1 hour, depending upon the resources and the setting. And also we use a fan to in a place once we get the patient to the our hospital, so that the cooling measures are more synergistic. So our aim is to, let's say it is 40 or 42 degrees centigrade. Our aim is to bring the temperature to at least 39 degrees centigrade, 38 to 39. Once this temperature is recorded, we better stop cooling, because we don't have to take the patient to hypothermia. Next slide, sir. So yeah, so once the temperature has we have reached the target, no need for cooling. Low body temperature, cooling contraindicated. So if we delay the cooling and think of scientific thoughts about the patient, there's a good chance of mortality. If it is a pure heat stroke, cooling first and then undress the patient, that makes sense. And air condition, good or no, because the colder water temperature produces faster cooling. Water's high thermal conductivity, which is 24 times greater than air, therefore water application is better than air conditioning. Next slide, sir. So emergency management, what not to do. Here also the slide is now words are missing. So what not to do. So here some of the words which I had written was not to use any depolarizing agents. Use non-depolarizing agents. Succinylcholine can be avoided. Instead, we can use atracurium or vecuronium. Likewise, these patients will have pulmonary edema or pneumonitis, or these patients will have some kind of ARDS. So make sure these we can intubate this patient to prevent aspiration. Also make sure the oxygenation is well maintained so that they don't go for hypoxia. Then the third thing was chlorpromazine, better to be avoided because that could be that can have some anticholinergic action. It could reduce the seizure threshold. It could also cause neuroleptic malignant syndrome, and also it could provoke hypotension. And also hypoglycemia should be monitored. And these patients needs adequate temperature management sometimes, because the temperature can come down, but later the temperature can also increase. So frequent temperature monitoring is important. So these are some emergency management that we have to do. Next slide, sir. Rectal temperature measurement. Of course, it is not very practical, but this is the method that has been recommended to maintain adequate temperature monitoring. Next slide, sir.
So can you hear me, sir? Murugan, sir?
Sir?
Sir, another 2 minutes, sir. We are running out of time.
Sure, sir. Sure,
Yes,
sure,
thank
sure.
you.
Sure, sir. So these are some of the techniques. Conductive cooling. Yeah, that is by cold water immersion. Next slide, sir. This is dousing in ice tub water. Next slide, sir. We have another like body bag cooling. It's another method. Next slide, sir. And the tarpaulin assisted cooling, making a swinging like oscillatory motion. Sorry, the photos are not there. Ice tower application is one other thing. Again, water spray, directed fan, water soaked bed sheets, and directed fan. Those are the things which I had mentioned. Next slide, sir. So targeted temperature 0.155 degrees centigrade. That's the minimum ideal rate where we can come to the cooling. Yes, sir. The next slide. So this is an easily reversible condition. If we act quickly, if missed, it is difficult. The permanent neurological deficit. Next slide, sir. So, and next slide. Yeah, do's. Stay hydrated, wear tight, wear light clothes, full sleeves, wear a cap or use an umbrella, carry water, carry a bottle with water in it, seek medical help if needed. Don'ts are avoid outing between 11 to 3 p.m., especially on a sunny day. Avoid dark colored clothes. Avoid drinking fruit juices. May not be a good idea to use outside fruit juice, bad fruits. And carbonated drinks, avoid. Don't apply talcum powder for children. That could interfere with the sweat glands. Avoid keeping chemical agents in water bottle. Keep that has to be kept away from children because they are innocent. There can be a toxic ingestion. Next slide, sir. These are my references. Next slide. Thank you very much. Thank you, sir.
Thank you, sir. Thank you for your extensive presentation, sir. We thought like heat stroke was a very small topic. It is very exhausted. And it was very informative, sir. Thank you very much.
Thank you, sir. Thank you.
Yes, sir. So if there are any questions, please raise your hands. Yes, sir. Zahid, sir. Sir, unmute yourself, sir.
Yes, sir. Done.
Yes, sir. Yes, sir.
Sorry, sir. How to differentiate between hyperthermia and hyperpyrexia?
Sir, no, again, between the temperature recording, sir, with this hyperthermia, mainly the history will give us a clue as to what exactly, what were the factors led to either is it a pyrexia or a thermia, and
Yes,
the
sir.
level of temperature,
Yes.
and with or without any comorbidities.
Yes, yes. It's about this febrile seizures.
Yes, sir.
Febrile seizures, what could be the cause of febrile seizures?
Usually febrile seizures that occurs in pediatric age group.
Yes, sir.
The rise in temperature which can cause some excitability or an aggressive electrical activity could be one reason, sir. But I do not know that answer correctly.
It happens from 6 months to 6 years of age.
Yes.
And it is can be because of the hypothalamus is not yet fully developed, sir.
I will have to look into it, sir. That was
Yes,
one
sir.
question. That's a boomerang question to me.
Yes. Anterior hypothalamus and posterior hypothalamus.
That's a good question, though. Learning
Way
question.
back in 1995, I studied about anterior hypothalamus and posterior hypothalamus.
Okay.
Anterior hypothalamus causes loss in heat. Posterior hypothalamus increases the heat, body heat. Is it correct, sir?
No, I was under the assumption that the pre-optic nucleus that is in the anterior hypothalamus has the thermosensors for this heat regulation, sir.
Okay, sir. And nowadays we are using infrared thermometers.
Yes, yes. But again, I do not know how much correct that could be. That is a quick application for us to understand, just like how we use a glucometer or a digital BP. But again, a thermometer kept on, especially in a rectal or an oral route would be ideal. But axillary being the most easiest. And now we also have some chest probes, sir, which you would have noted in our ICU settings, that also could give us the body temperature.
I have recorded up to 105 degree. I have recorded up to 105 degrees Celsius with infrared thermometers, sir.
Okay. Okay.
Yes, sir.
Yes, sir.
Thank you for your presentation, sir. Extensive presentation.
Thank you.
Can you? Yes, sir. We'll go to the next session, sir. Thank you,
Thank
sir.
you so much, sir.
very
Thank
sir.
you. Saki, sir, that was a good question. I'll get back to you, sir. Thank you.
Thank you, sir. Thank you, sir. Okay.
Thank you, sir.
சரி நான் கண்ணு பார்க்க போவா கண்ணு கண்ணு
So is dandelion sodium available? So is dandelion sodium available for malignant hyperthermia?
Sir, was there a question?
Is dandelion sodium available for treating malignant hyperthermia as per Davidson?
Yes, sir. Yes, sir.
Yes.
அதனால விட மாட்டேங்கிற ஹேஜ்ரி திருப்பி திருப்பி
Speaking for
கொஸ்டின்
the day,
செக்ஷன் வரும்ல
who are present here, Dr. Sridhar Subaya from Madurai, Dr. Vijay Bhaskar, surgical oncologist from Madurai, Meenakshi Mission Hospital, and Dr. Sundar. So the other dignitaries who are felicitating us from online are Dr. Gunasegaran sir, National Vice President, IM Headquarters, Dr. P. Sengutuvan sir, State President-elect, and Dr. Gauri Shankar, our Honorary Finance Secretary. So the rest of the dignitaries are present here. Sir, Abul Hasan sir, I think is offline. We'll call him. Sir, Abul sir, can you hear us, sir?
Yeah, I'm here. Very much here. Anand, good evening.
Yes, good evening. Sir, you are online, sir. You can speak, sir.
Yeah.
We welcome you to the first inaugural session of the South Zone CGP conference, sir. So the offline session has been done already, sir. The online session has been done, and offline we are going to start, sir. We request you to give you a kind presidential address, sir. Thank you, sir.
Thank you, Anand. Good evening, all of you. Respected President-elect Dr. Sengutuvan, Dr. Sridhar, Honorary Secretary Dr. Kartik Prabhu, Finance Secretary Dr. Ravi Shankar, Gauri Shankar, and all the dignitaries, the dais in Ramanathapuram, all the delegates, dais, CGP South Zone. Very nice. Good evening to once again all of you. I'm very happy to participate in this South Zone conference. Also, the inauguration of course on respiratory medicine. IMA CGP is taking the flag of IMA CGP to greater height, and I'm very happy that our branch, our unit of CGP in Tamil Nadu is most vibrant branch in the entire country, doing all academic programs regularly. And I can see the delegates, both juniors and seniors, participating in this, because we all know that learning is a continuous process in medicine. And the topics which are chosen are very, very timely and also full of messages, take-home messages, and can be applied immediately in the day-to-day practice. So the topics and the faculty is also very good. I extend my heartfelt gratitude to all the faculties who are time and again agree to our request and give their valuable addresses whenever is invited. Thank you, all of them. And also, I think we are evolving in conducting CME programs very fast. Now we are from lectures to CME programs. We are moving ahead because, otherwise it may not be very much attractive. So we are conducting courses to attract more people. Courses is become a way of learning today. And also, I would suggest that to keep all the participants engaged continuously without any break. I wish all the addresses, talks are very good and full of messages. So my only wish is that all the participants are connected continuously without any break. This is a huge task because it is time consuming lectures. Sometimes today we have many lectures, though all are important, many lectures. So audience may sometimes disconnect and go and come back. So we can also innovate a kind of giving a quiz paper in after every lecture, all or at the end of the lecture. So give them 2-3 minutes time based on the lectures which are given, so that you can give marks and the winner also can be announced within a minute time. And also you can publish the names of the winners at the end of every webinar. So this would encourage people to actively be engaged in the thing. I think the coming webinars or talks on Zoom can apply this so that the people will be immensely benefited. And our team of IMSCGP, Anand Chaklingam and Sendil Kumar, Rajesh, all of them are doing a wonderful job, sharing lots of their time, energy, and resources for the sake of learning of all our members. This is a hugely appreciable task, and I congratulate as a president and also on behalf of IMA TNSP, the CGP team, which is actually giving an academic explosion in the state. Thank you very much, IMA CGP. Continue your good work, and I wish all the delegates and also Ramanathapuram colleagues all the best. And thank you very much for organizing such an event in your place. And have a very good day. Thank you very much. Over to you, Dr. Anand.
Thank you, sir. Thank you for your kind words, sir. We'll try to keep up with your pace, sir. Now, next I request our State Treasurer, Dr. S. Karthik Prabhu, sir, to give his address.
Most respected President and all leaders of the state, branch, Ramnath district and all the wings. Good evening, everybody. First of all, I would like to congratulate CGP ஏன்னா இன்னைக்கு வந்து கிட்டத்தட்ட more than 750 people have attended. And I think henceforth, most of the meetings in the branches, I think we should have a permanent hybrid theater so that I think we should also change trendy. But then there is always a pleasure of having a live meeting. I think Anand sir and Sendil have made it live, where half 50% is offline and 50% is online. So, and for the benefit of everybody, this is 750 is a very good number. I congratulate your team for that, sir. That is something which is very good. And again, Ramnath branch, wonderful venue, very, very, very nicely hosted. So thank you. Best wishes for that. Just 2-3 points I want to add, sir. இப்போ எப்படி சிஜிபி வந்து இஸ் டு எம்பவர் தி நாலேஜ் ஆஃப் ஜெனரல் ப்ராக்டிஷனர்ஸ், ஏஎம்எஸ் டு எம்பவர் த ஸ்கில்ஸ் ஆஃப் ஸ்பெஷலிஸ்ட். அந்த மாதிரி நம்ம எஃப்எஸ்எஸ் வந்து அண்ட் பிபிஎல்எஸ்எஸ் ஆர் டூ வெரி வெரி இம்பார்ட்டன்ட் ஸ்கீம்ஸ். அண்ட் ஆல் த 750 people who are here inside, I would request them to please join the schemes. Whenever we are practicing, we have a problem and we are there to face the problem. PPLS is going to help us. At the same time, when we are not there, for our families to face the issues, FSS is going to help. And a good volume, more than 9,000 people are there. So please join, please motivate people. Nowadays, youngsters are at the highest risk. People always think we'll get into these schemes when we get older, but the highest stress is in the youngsters. And youngsters, it is also cheaper. The joining fee is very less. So make use of it. Keep your family safe. Thank you. Thanks for the opportunity. Best wishes to CGP and team. Thank you.
So thank you, Karthik Prabhu sir. Thank you for your kind words and words of encouragement. Next, I would like to call upon Dr. Gunasegaran sir, our National Vice President, IMA Headquarters, to give his felicitations, sir. Gunasegaran sir, can you hear us, sir?
Yes. Good evening,
Yes,
everyone. Respected State President Dr. Abhulasa, State Secretary Dr. Karthik Prabhu, State Vice President Dr. Khalilur Rahman, President-elect Dr. Sengutuvan, Dr. Sridhar, and all the dignitaries in the dais at Ramanathapuram, respected Chairman of the CGP Tamilnadu faculty, Dr. Sendil Kumar, the organizer and the enthusiastic secretary of the faculty of Tamil Nadu, Dr. Anand Chakalingam, and all the faculty members and the delegates participating today in large numbers. This is a huge success, as Dr. Karthi is telling, that many members are participating in this online mode. So this South Zone meeting is a wonderful and successful organized meeting. I congratulate the organizing team, and I invite all of you to enroll for the South the South Zone All India CGP conference at Rajamundry on 3rd and 4th of August, which is a live one, where you can directly acquaint with the many international speakers. I congratulate the team of the Tamil Nadu State faculty for the wonderful program today. Thank you. And I also congratulate for the respiratory medicine course, which they are starting as a certificate course, and best wishes for the respiratory medicine course also. Thank you. Thank you.
Thank you, sir. Thank you for your words, sir. Next, I would like to call Dr. Sengutuvan sir, State President-elect 2024, to give his words of felicitation. Sengutuvan sir.
Sir, yes. Good evening, everybody. Respected President Dr. Abdul Hassan, respected National Vice President Gunasegar, President-elect Dr. Sridhar, Honorary Secretary Dr. Karthik Prabhu, Finance Secretary Dr. Gauri Shankar, Director of Studies Sendil Kumar, Active Honorary Secretary Dr. Anand Chakalingam, and other dignitaries on the dais and other delegates. Good evening, everybody. CGP is doing a wonderful job. During my time, I was the Director of Studies last year. We have conducted a program the same type, online and offline at Pollachi, and so many people are attended the program. Likewise, the program is going to be a successful one. I wish and congratulate the Ramanathapuram team for their continuous support for this program and everything. And active courses are, many courses are conducted by the CGP, and I request all of them to join to enlighten your knowledge. As Karthik Prabhu said, you have to join, make member to join on FSS and PPLSS. No many cases are coming in the hospital side. So we have to protect the hospitals and your families. So request all the members to join the FSS and PPLSS program. And I once again congratulate the CGP team of Tamil Nadu. Thank you for the opportunity. Over to Anand.
Thank you, sir. Thank you for your words, sir. Now I request Dr. Sridhar, sir, President-elect 2025, to give his words of felicitation.
Good evening, everybody. Thank you, IMA, TNSB, FSS, for this great, wonderful opportunity. And most respected President, Dr. Abul Bhai, Karthik Prabhu, Gauri, the team, CGP, Sendil Kumar, Anand, and other team members, the host, the wonderful, sweet, entertaining host, IMA, Ramnad, and all the delegates who are coming here in person for this offline part of it. Very good evening to you all. CGP had been very endearing to me because I have served as faculty secretary CGP and then as joint secretary national CGP. That was the first time we took CGP to the branches like Arandangi, Srivilliputtur, all remote branches, Mayiladurai, and that was the time when Skype was very popular. So we arranged leaders to address through the Skype. Dr. Jailal addressed the gathering at Arandangi from Marthandam through Skype. That was the first, I think that was a forerunner to this sort of online and hybrid meetings. I'm very happy to share that information with you. And to have an attendance of 700 and odd is something stupendous. Congratulations, team CGP, for that. இதில் எனக்கு ஒரே ஒரு கவலை வந்து கார்த்திக் பிரபு லைட்டாக டச் பண்ணாப்புல. He just simply touched on that. By this sort of remote attendance, we are losing chances of meeting our own people. And this meeting should have more people to attend locally. So the academic excellence, இன்னைக்கு நிறைய opportunities. யூடியூப்ல போட்டு கேட்டிங்கன்னா உடனே ஒரு வீடியோவோட you are getting some information. So getting knowledge is very easy nowadays. But to get to know people who are practicing with you in the same city, you may cross them in a shopping mall, but you may not know that he is your colleague in the town. I think that is one avenue we have to be very careful about when we encourage such online meetings. The local members should be encouraged to come and attend the offline meetings like this happened today, and I congratulate Anand for that. So we are very happy, and we wish you more success, and we to conduct more such meetings in future. All the best, team CGP. Thank you so much.
Thank you very much, sir. So this is the first meeting, so we are training ourselves, sir. So next we are planning to do in July, July 13th in Pollachi, sir. It's a national conference. Then in Vellore after 3 months, North Zone. Then the East Zone will be finally in Trichy or Tanju, sir. We are planning for it, sir. Thank you for your words of encouragement, sir. Next, I call upon our own son of the soil and Vice President of Tamil Nadu State Branch, Dr. Khalil Rahman, sir, to give his words of felicitation. Sir.
Good evening to everybody. Respected President, and the dignitaries on the dais, and off the dais, and all the members of this evening. This is a very great occasion that we are gathered around 700 plus members in this course. The Anand and the team has put up messages in the WhatsApp groups, in all the WhatsApp groups, that they cannot see any other messages other than CGP messages. That much of messages they have put up, and they have arranged this much of people participated in this program because of this large number of messages. Congratulate the team wish them all the success. Thank you very much.
Thank you, sir. That was very kind of you, sir. So next, I think I request our Secretary Ramnavaram branch to give his words of felicitation. Dr. Vatsavaran, sir.
Good evening to everyone. I think, as I said, it was really a wonderful occasion. I really enjoyed the talk of Karthik Prabhu. And the message he passed on was very crystal clear. Sir, 4 things you have to do. One thing is you enrich your knowledge, upgrade your knowledge to serve the public and enrich yourself. That's one. And the second thing he pointed out is AMS. That's a skill for people who are already qualified to improve their skills. It all carries really a great value. I never knew that probably these youngsters do a lot of interesting work. We have been always thinking that olden days were the golden days, but things have changed. And the third thing he rightly pointed out, when you are in trouble, only IMA can come for help. Neither your advocates nor your political bureaucrats, they may not be helping you. He rightly pointed out this PPLS. It was really touching. He talked very sensibly, very clearly, very beautifully. And the fourth thing he talked about was, I think that when you are going to lose one of your members of the family, the bread earning member, IMA is going to come for the help. That's really a great message, Karthik. I think that one of the great lectures that I have heard, because this is the message that has to be passed on to the whole country as 4 pillars of of an organization or 4 pillars for a chair. This message has to be, I think it has to be conveyed. That Abul Hassan rightly whatever he talked was very crystal clear. He was very clear in his thoughts. How CGP has improved, how we are as a best runner in the country, one of the best vibrant.
Sorry to interfere, sir. Unwanted voices are coming, sir.
These 4 items plus CGP. So really, it is a wonderful event. And the thing he pointed out rightly was, Sridhar said, you can add any number of lectures through videos, be in your chamber and hear anything. But socialization is what we are lacking. Now the number of doctors have increased and socialization is slowly coming down. And that's not a good sign. Now, because I've traveled internationally, the socialization is very much there. Everywhere, every day they have a meet. Every day they have a meet. But not at the expense of somebody else. They join together, they bring 1 meal or 2 meal or something, some all thing, but everybody sees to that monthly 4 times they meet. The only thing is not only socialization, there is no difference of opinion among them. It gets cleared off then and there. So as he rightly said, there are about 700 people who have joined for an online meeting, but we are not very happy to know that the hall is still not full. But one thing, probably it may be the fault of the IMA secretary. We have not wooed the more participants. We have not at their doorsteps. We have not invited them for the weddings. Or I think, no, I feel very bad. I feel very bad. So I thought probably I have not done my job. So that's why at this point of time, at this age, probably I should not have taken over as a secretary. Some youngsters should have taken over. Probably a wrong thought. And I think Praveen and myself has to revitalize and rethink and then try to get members more. No, I am very much worried, Sridhar, as you said, a lot of deliberations can happen through videos. But once you meet, absolutely true. I do not know, somebody, I have seen so many people somewhere in there, and I said, who is this gentleman? I have not seen him at all. Sir, he is your colleague, he is doing this profession, this part of the city. That's true. So these are all very, it is right from the bottom of the heart. I realize it. I think I'll try to achieve that. The hall is always full. And I think the lacunas will be filled up. But you should also take some responsibilities. I felt awfully bad when GS told me the message has not reached. So I think, and I should appreciate Dr. Abulazan, even though they are all quite juniors to me, but I have served for PNGDA more than 25 years. Those were the different days. Now the days are becoming more digitalizing, and the LED will be able to see how a hybrid meeting has given a lot of informations. And I really appreciate Anand Chokaliyam for his effort to make this center as one of the centers of excellence with a hybrid and the speakers are also excellent speakers, right from the from Meenakshi Mission and Sridhar, professor of endocrinology, who trains a lot of young endocrinologists throughout the India. He gets only candidates from either from Himachal Pradesh, Simla, and outside the state. And Dr. Sundar, he, as always they used to say that he is son of the soil. He is beyond that. And now he is one of the jewels of the crown of Kaveri Hospital. So these are all things. They have taken all the pains to come here, and we'll also try to use them and we'll learn to them. Thank you very much, Anand, for making me wise. Yes, I'll feel that.
Thank you, sir. It was an open confession, and I really appreciate this should be the way to lead. Leader should be, sir. Thank you very much for kind words. So next, I think we'll go to the on a personal in person mode. Now, unfortunately, one of our speaker who was supposed to come directly, Dr. KG Srinivasan, he is held up with the personal work, so he's online now. So next talk will be Dr. KG Srinivasan online. Thank you. Sir, KG Srinivasan, are you online, sir? Yes, sir. He is online. Thank you, sir. I request the delegates to be on.
Can you hear me, sir? Hello?
Yes, sir.
Yeah. Can I start? Yes.
Sir, you can start, sir.
Yeah, please. My sincere thanks to Dr. Anand Chokalingam to give me this opportunity. Today's topic is CT-MRI diagnostic essential for general practitioner, must know conditions. Before ultrasound, CT and MR era, what is opinion of physicians, pediatrician, OGCN, surgeons about radiologist? It is, these fellows are nothing but useless bunch of people sitting doing nothing like that only. The modalities have come, including radiograph, ultrasound, CT scan, CT visual scopies, 3D CT, 4D CT, MR, MR angio, veno, spectroscopy, MR neurogram, myelogram, DSA, PET CT, SPECT CT. The things have been changed. William Conrad Ranjan, who invented X-ray in 1895, who is called father of radiology. It is his wife's X-ray, and he got Nobel Prize. It is in front of his museum, and it is now, you can see that his house. And CT was invented by Sir Godfrey Hounsfield in 1972. He is called father of CT. This is the first CT taken in 1972. You can't see anything, only pixels only you can able to see. Now, state-of-art engine, we can able to beautifully appreciate the gravity discrimination with the right thalamocapsular bleed with intraventricular extension due to hypotensive intracerebral hemorrhage. We are proud to say first 64 slice in Tamilnadu introduced at Madurai 2004, and first 128 slice sensation that is also introduced. Somatum definition, it is also introduced in Madurai only 2007. And the first twin beam dual energy is introduced in Madurai only. First world's twin beam dual energy. It is 2019. And why so much advance is essential? Because this is, if you are safely seeing, this is only 18 days old child presenting with features of hypertension, and lower limb pulses are not felt. And with 3 ml of contrast, we can able to do aortic angio beautifully. And what we are seeing is a classical, you can see the defect over here. This is the classical defect, and you can see the quotation of aorta, which we can able to diagnose it. You can see the quotation of aorta over here. This is possible nowadays. MR is invented by Edward Felix Bloch and Edward Bursell. These are the two guys who invented, and Raymond Damadian, who is called father of MRI, and first TIM technology of 1.5T introduced in Madurai only. And why this TIM technology is essential? Because we can see the spine as a whole, whether it is fractured, dislocated, or cord injured, or it is a multiple sclerosis involving the cord as well as the spine. Everything we can assess without changing the position of the patient or changing the coils, which is possible nowadays. We can see the multiple fractures also here. And same thing, this is one case, how it is surpassed the rest of. Initially, we were doing only lumbar spine means lumbar spine. We cannot do whole spine. This patient was having some lesion at the lumbar region. He has been operated. You can see the laminectomy defect, but the patient was not improving after surgery, further progressing. This is the same patient, whole spine. You can see the post-operative site, but also missing the lesion at mid-thoracic level, a cerebellar lesion. It's a case of one equivalent with the cerebellar and mid-thoracic cord hemangioblastoma. So which is possible nowadays only with this TIM technology. Otherwise, we will not get it. We will do only lumbar spine, then we have to go to thoracic spine. It is not nowadays. Only 2 stations we can able to complete the entire spine system. Same thing, to assess the vasculitides or vascular disease, whole body MRI is possible with the 3 stations. With the 7 ml of or 8 ml of Gado, we can able to finish it off from head to foot. Whole MR we can able to take. We can channelize the where is the vaso-occlusive, or it is aneurysm, or is it something else. We can able to diagnose it. And one advantage of newer engines are viability studies and cardiac MR. This is beautiful appearance of transmural impact of left ventricular apex and LV thinning, and we can able to see post-Gado, late Gado enhancement of distal interventricular septum, LV apex, and a transmural impact. That means that myocardium is not viable. So whether the vascularization is useful or not, all these things can be assessed nicely. You can see the left ventricular dilatation, it is post-ischemic DCM, and you can see the transmural impact along the LAD territory. So confident we can give in to the surgeons whether this it is useful or not, and a good calculation of ejection fraction of right ventricle as well as left ventricle can be possible in seconds with the possibility of good MRs. And the 3 Tesla almost changed so much of neurology. Fine tuning, you can see this patient had injury, had severe left arm weakness, classical neuropraxia as well as oxygenatomesis. We can able to say confidently. And tractographies as well as DTA, which will fine tuning the neurological diagnosis as well as prognostication of the most of the diseases is possible with the help of tractography. The 10 must-to-know conditions, 10 means I have included 3 or 4 most important conditions. This patient had seizures, right side focal seizures, and this is a 0.8 millimeter slice. This is post-contrast 1 millimeter slice, and this is called 3D cyst. This sequence will help what is happening. This is 0.8 millimeter. We can able to see the lesion less than 0.10 or 1 millimeter less than 1 millimeter. This is classical cystic sarcosis with the surrounding edema. This is a collateral stage of cystic sarcosis with the marginal squalex and surrounding edema and ring enhancement after IV contrast. Beautifully, we can able to assess it. This is case of cystic sarcosis. So confident diagnosis we can give. After injury, if the patient is having biconvex shaped any hematoma, this is called extradural hematoma or epidural hematoma, and you can able to see. So it is very much essential and emergency. We have to evacuate it because the midline shift, everything very essential. And one important sign is called swell sign. This is active bleed. You can see the fracture, and you can see the fracture. It is actively leaking. This is very much essential, and you can see the midline shift started coming. So it's an emergency. So any biconvex, it is an emergency. It is extradural hematoma. You can see here. And subdural hematoma, acute, you can able to see the biconvex. You can see the concavo-convex appearance. This is subdural. There EDH is biconvex. Here concavo-convex appearance. You can see the like semi-lunar appearance. You can see the classical appearance. And you have to give the bone window dark. Then only we can able to here the same patient with the brain window. We cannot assess the subdural. The bone window, after suppressing it, you can able to see the subdural beautifully. So adjusting the bone is very essential to identify it. This is subacute phase of subdural hematoma with the gross midline shift. And this is subacute phase of subdural on right side. So carefully we have to look into it. Otherwise we may miss it. You can see the subdural hematoma. So carefully we have to look. And chronic subdural hematoma over here, you can see the chronic. If you are carefully seeing, only we can able to see. So the hematoma by the age, you have to carefully assess. Here the bilateral subdural hematoma on both sides with the compression of the brain parenchyma. These are the things very much essential. We should know it. And this is doing surgery, and you can see the subdural hematoma evacuated. You can see that the pressure, so much pressure it is pouring out, and we can give cure to the patient. This is possible nowadays. And especially diffuse axonal injuries, cortical, subcortical injuries, burst temporal lobes, burst frontal lobes. Here, after trauma, patient is unconscious. GCS is 3/15. You can able to see a large right frontal lobe hematoma, right side frontotemporal, subdural hematoma, and large parenchymal hematoma, intraventricular hematoma, subarachnoid hemorrhages, and the midline septal crossly seen towards left side. So these things are, we can able to give the diagnosis. This patient, hypertensive individual, sudden onset unconsciousness with left side hemiparesis. What you are saying is the hypertensive intracerebral hemorrhage in thalamo-capsular region, dissecting into ventricular system with clots in lateral ventricles and hydrocephalus. And you can see the intraventricular clots, and you can see the midline septal also. And how to differentiate hemorrhage from infarct? Infarct, because of cytotoxic edema, what you are seeing is the hypodense attenuation because of water content. And how to identify the territory? Is it MCA territory or ACA territory or PCA territory? A is the first letter, so anterior. You can see the anterior to frontal horn, it is ACA territory. MCA, M, middle letter, so you can be able to see the MCA territory. P is the posterior, you can see the PCA territory posteriorly. And in between watershed zones, MCA, AC, and MCA, PCA watershed area. So it's classically we can able to difference. Now it is MCA territory with MCA, PCA watershed is involved. So confidently we can give the diagnosis, it is infarct. How to differentiate arterial infarct from venous infarct? Arterial infarct will obey the territory. Venous infarct, it will not obey the territory, and veno-occlusion also we can able to see. Here it is arterial infarct, venous infarct with the hemorrhagic areas here and there, and you can see the thrombus in the superior sagittal sinus, frontal cortical vein, and you can see the posterior aspect of the superior sagittal sinus. All these things are thrombus. So this is the simple way. It will not obey the territory, and it will be invariably it is hemorrhagic. And we can see the cortical vein thrombosis here. You can see the frontal cortical vein thrombosis, superior sagittal sinus thrombosis, and this is the one responsible for the venous infarct. This is the one how to differentiate it. How to identify the extraaxial lesion, that is tumors. This is classical appearance of ice cream cone-shaped extraaxial tumor with a small intracanalicular, large extracanalicular component, cystic degeneration, and CSF entrapment, compression of brainstem, fourth ventricle, cerebellum, and the patient presenting with vertigo, giddiness, as well as some form of ataxia with hearing loss. That is classical case of vestibular schwannoma on right side producing like this. And this patient presented with right side hemiparesis with the fits, and we can able to appreciate extraaxial meningioma. You can see it is outside the brain, and the dural tail sign is there, brilliant enhancement and anastosis of the inner tubule with the good vascular supply surrounding perilesional edema. And you can see the alanine peak over here and the lipid lactate and mild elevation of colon. All these things are very classically seen with highly vascular meningiomatous meningioma of the left frontal convexity attaching to the pterion. This is classical location. This patient presenting with visual symptoms. What you are seeing is the splenium of corpus callosum lesion with brilliant and heterogeneous enhancement, central necrosis, surrounding edema, extending into the peritoxiptal white matter. And you can see the colon peak is sky high and a very highly elevated lipid peak as well as lactate peak. That means what we are dealing is the IDH, it is IDH resistant and IDH, so it is very classical of GBM, glioblastoma multiforme with involvement of splenium of corpus callosum. That means the prognosis is poor in this patient. And ring lesions, how to narrow down the diagnosis. Ring lesion, it may be of abscess, it may be of tuberculosis, it may be of fungus, which may be of toxo, which may be of cysticercosis. Cysticercosis, you can able to identify the scolex. In TB, it will be of ring lesion with the T2 low signal, central low. This is very classical appearance, and the spectroscopy will show lipid peak, and this is tuberculosis. And in pyogenic abscess, it will have dense diffusion restriction. Diffusion restriction will be very high, marginal enhancement will be there, and you can see a three-layered capsule will be there. This is very classical of pyogenic abscess. There is not much hemorrhages in the capsule. It should be differentiated from fungus, where you can see the margin will be irregular, and you can see the margin as well as adjacent inner areas will show the hemorrhagic areas, and you can see the only marginal diffusion restriction and enhancement of trivicant. These are all very classically seen with the fungus. And toxoplasmosis commonly seen in immunocompromised host, thalamic area involvement, subcortical involvement, and it is peripheral target sign or spleen pod appearance, and this is very classical appearance of toxoplasmosis. All these things where the CBVs and perfusion is very, very low, and these things how to differentiate ring enhancing lesions. And MR is the modality of choice to identify the acute stroke. This patient presented with right side hemiparesis, and you can see now immediate right, we take it within 10 to 15 minutes, so we can't able to identify anything in the CT. MR we have done T2-weighted images negative, FLAR is also negative, but diffusion we can able to appreciate that small acute infarct in left internal capsule, and you can see the restricted diffusion with the low ADC. But the MR angio completely occluding, you can see the complete occlusion of the stem of MC. You can see the M1, M2, M3, M4, nothing is seen. And this is perfusion study. You can see the large area of perfusion defect. You can see the diffusion, perfusion mismatch is there, class mismatch is there. And so these are the things now newer advanced. We can able to give the consultant, neurophysician or physician, that this is a window period. Within 3 hours he has come. We have diagnosed a stroke with the diffusion perfusion mismatch. So you can thrombolyze, we can do cure to the patient. These things possible nowadays. And especially patient coming with the chest pain, 3 causes should be ruled out. One is pulmonary embolism. You can see the thrombus. You can see the thrombus in distal RPA, LPA, and you can see the dilated MPA. This is very classical of pulmonary embolism. Aortic dissection, you can see the large area of intimal flap traversing from the arch, from the distal arch, it is coming to DBAK type 2, when they're not involving the ascending aorta. This is very classical of aortic dissection. And acute coronary symptoms, you can able to appreciate there is a typical appearance of, it is see that you can see the complete occlusion of after mid LAD, after D1, and you can see after stenting, you can see the before stenting, after stenting, which is possible nowadays. You can give the confident diagnosis. And the negative predictive value is nowadays 100. If you are saying no, means it is no. The percentage may be vary when there is calcification. Virtual angioscopy has come, it is helping a lot to diagnose and fine-tune the coronary diseases. Coming to a few chest slices, this is very classical active PT. Chest is called cavitary lesions, and you can see the surrounding central train bud infiltrations. That means it is active PT with endobronchial spread of infections. It is very classical of active pulmonary tuberculosis with endobronchial spread. And this patient suddenly presented with the chest pain, and we are able to appreciate the large area of pneumothorax. Where is the source? This is the subpleural blood which has ruptured, and it is producing large area of pneumothorax on right side. So confident diagnosis we can give what is the source of pneumothorax here. This patient presented, rheumatoid arthritis patient presenting with the respiratory symptoms and strong suspicious ILD. What you are seeing is the classical appearance of a reticular pattern with the interlobular septal thickening and honeycombing, micro and macrocystic honeycombing, and traction bronchiectasis, architectural distortion, subpleural involvement, and both lungs are involved. Very classically RA-ILD with the typical pattern of these things. Abdomen, few slices, what the patient is presenting acute onset abdomen. Is it urinary colic, or is it sigma diverticulitis, or epiploic appendiditis, or it is acute appendicitis? You can see the stone in this is such a coronal reconstruction. Confidently, we can give the surgeon what we are dealing is the left distal urethral calculus response for the symptoms. This patient presented with RAF tenderness. We can see the classical appendicitis with the appendicular as in fluid collection within the appendix, possible the fluid collection in the appendix surrounding focal peritonitis. You can see the confident diagnosis to the consultant, whether it is ruptured appendicular abscess or mass formation, what is the status of the adjacent structures, all these things we can give the diagnosis. Coming to few slices of the spine, and you should know whether it is bulge, protrusion, extrusion, or sequestration. This is one best example, extrusion. That means both inner and outer arnold fibers have gone. The nuclear material came out and compressing over the thecal sac and nerves. This is indication for surgery. It will never go back. Bulge means just outer arnold cell alone gone. It may medically manageable. And the sequestrated disc means the extruded material losing its continuity. You can see the material came out and losing its continuity. It is migrating downwards. That means it is indication for surgery. So confidently we can give the message to the consultant that this is a case for surgery. Patient presenting with the cardiac symptoms, sudden onset urinary problem, urinary retention is there. That means we should operate immediately. And this patient presented with the headache, back pain, and neck pain, and it's a typical case of multiple myeloma with the punched out destructive lesions in the skull vault. You can see the punched out multiple destructive lesions. You can see the sternal dissection, vertebral dissection, pathological fractures. And this is possible. You can see the multiple destructive lesions in skull vault, periorbital region. Presenting with proptosis, headache, orbital pain, as well as back pain. It's a case of multiple myeloma. Last few slices of interventional radiology. Interventional radiology nowadays have come up like anything. We can do biopsies. We can approach anywhere which surgeons cannot approach. You can see here, there is a restricted lesion. Posteriorly, he cannot go. Anteriorly, vessels are there. Laterally, we can go. And you can see it's a case of biopsy proved tuberculosis of the vertebral column without perivertebral abscess. We can do biopsy. And parietic node, you can see the posterior approach. We can go and give the exact material to the pathologist that what we are dealing is. And this lung biopsy, you can see the material is gone inside. And the liver abscess aspirations, which is possible. You can see the pseudopancreatic cyst aspiration. These are all possible nowadays. We can help the consultant, and definitely it is possible. So after CT, MR, ultrasound, and SPECT CT, PET CT, and the useless people nowadays, we became very useful people to the consultant, sitting in AC room, but doing the DIGOD work to the society as well as the medical curriculum. Thank you very much.
Thank you, sir. That was a very good talk for the general practitioners and how to diagnose, sir. So any questions, it's open to the forum. From our audience here, any questions?
I have a doubt. The explanation regarding disc bulge, can it be explained once again, sir? Disc bulge protrusion.
Yes, no problem. Madam, disc is having central nucleus material surrounding.
It was an excellent talk. I am really there.
Yes, so disc is having central. Thank you, sir. Disc is having central nucleus and surrounding annulus. Annulus is having two fibers, inner fiber as well as outer fiber. Bulging means annulus is intact, just it is bulging outside. There is no need, invariably no need for surgery, because it will go back or it will pliable and it will go back to normal. The second stage is protrusion, where inner annulus will be gone, outer annulus will be intact. So it is protruding outside, but it is not extruded. If the annulus have totally gone, inner and outer fiber, so the nucleus material will come out and it will hang down, it is extruded. Then definitely it will never go back. It may go right or left or paracentral or foraminal or extraforaminal. And according to the site, it may present. If it is central, means definitely it will produce cardiac symptoms. Paracentral means it is root compression. Sequestrated means it will lose its continuity. So it may go even 2 or 3 vertebral downwards or 1 vertebral downwards. So third and fourth stage, extrusion, and this is main indication for surgery. That is one thing we have to. Then, and I can even draw and I can show the I can draw here. You can see, I think I will show my share screen and I will 1 minute, I will draw it and you can able to appreciate what is the.
Okay, sir.
1 minute, madam, just a minute, and I will.
Yes, sir.
You can able to understand it nicely. I will show the. So normally disc will be like this, central nucleus will be there and there will be annulus, and this is like this. This is normal. If it is bulging means it is intact, but it will bulge out, whether it is bulging on one direction or but it will be totally intact. This is classical appearance of bulge. And protrusion means it is there is a lac will be there, and this is and conductive material will come out, but here outer fibers it is intact, and you can see the outer inner fibers are intact. It will come out, and extruded means it will come out like this, where totally the nucleus will come out like this, and we can able to see the like this. So the nuclear, and this is extruded, and sequestration means it is totally, we will have discontinuity here, and so it will migrate down. So this is the various stages from normal to bulge, bulge to protrusion, protrusion to extrusion, extrusion to sequestration.
Thank you, sir. Thank you so much, sir.
Thank you. Thank you.
There is a question, sir.
Yes, sir.
Please explain how to identify infarct and hemorrhage again.
1 minute, sir.
Differentiation between infarct and hemorrhage.
Yes, hemorrhage will be hyperdense because of heme as well as globin. Globin is protein, and hemorrhage and globin will be, we can able to, I will show you, sir. And according to the stage of hemorrhage, CT it is very easy hemorrhage will be hyperdense, and this is very easy. We can able to pick it up, and this is simple way. And this is hemorrhage. What we are seeing is the hemorrhage. You can see the hyperdense attenuation. So it is hemorrhage. It is of acute nature. If it is of going for subacute and chronic, we cannot differentiate, but it will be also hypodense, very difficult to differentiate from infarct. It is acute hemorrhage, so we can able to see hypodense attenuation. It is thalamo-capsular hemorrhage dissecting into ventricular system, intraventricular. If it is infarct, means it is acute infarct. You can see the acute infarct. I am not talking about hyperacute. Acute infarct, intense cytotoxic edema, water content will be more, and there will be absence of Brownian motion, and you can see the edema. That's why it is hypodense water. It is hypodense, and it is concerned with arterial infarct, not thrombolysis. If it is going for thrombolysis, it will become hemorrhagic component also. Venous infarct without thrombolysis also it will have hemorrhagic, and this is the territory. Anything anterior to frontal horn, ACA territory. Anything posterior to posterior horn, it is PCA territory. Central, it is MCA, MP. That's ICA, and here it is watershed areas. And you can see there. And the hemorrhage. And this is venous. You can see the venous infarct, some hemorrhagic areas, and you can see the thrombosis in the vein. You can see the superficial sinus thrombosis, and you can see the frontal cortical vein thrombosis also. So how to differentiate? This is the one. But nowadays, newer sequences in MR have come, SWA sequence, which can differentiate various stages. Is it oxyhemoglobin, deoxyhemoglobin, or methemoglobin, or ferritin, or hemosiderin? What is the stage of blood products within? Is it intracellular or extracellular? All this is can be we can able to differentiate in MRI. So much advances have come up. Thank you, sir. Any other question?
Question, sir.
Yes, sir.
Yes, sir. So difference between the
significance of calcium scoring and CT angiogram.
Yes, sir. CT angiogram, see, it is not nowadays, because when it is more means it is definitely vessel is calcified, but intraluminal how much it is narrowing, that is very, very essential. And the same thing nowadays FFR has come, functional fractional flow rate, that is also very much essential. And what is the plaque status? Is it ordinary plaque or vulnerable plaque or ulcerated plaque or anything thrombus is there? Whether it is mixed plaque, where it is situated, and the flow anterior to plaque, flow at the level of plaque, flow posterior to plaque, all these things we can able to now assess. FFR, that is called, which is one which is going to decide most of the things. And when we are doing angio also, what is the perfusion of the area which is supplied by that particular vessel? That's also nowadays we can assess. We are going to get that engine in another 1 or 2 months, which will give more beneficial to the surgeon as well as physician, whether which is vulnerable or not. All these things we can able to identify. Calcium scoring is the one initially we are doing as a screening protocol. Now not much useful because patient may be having heavy calcium, but intraluminal it may be patent. You cannot differentiate. That's all.
Discussion.
Any
Thank you very
question?
much, sir, for your extensive discussion for the general practitioners.
Thank you, sir.
Thank you for your sparing your time amidst a busy schedule, sir.
Thank you, sir. No problem.
We thank you on behalf of IMA Tamilnadu State Branch and the CGP wing of state, sir. Thank you, sir. Thank you very much, sir.
Thank you.
Thank you, sir. That was great, sir.
Thank you. Thank you.
So then next I invite our speaker for the day, Dr. Vijay Bhaskar, surgical oncologist from Madurai Meenakshi Mission, who is going to give a presentation on basics of surgical oncology to the general practitioners. So your stage is yours, sir.
Good evening. Good evening, everybody. It's indeed my pleasure and privilege to stand here to deliver a small talk on the basic concepts of oncology for general practitioners. I thank IMA CGP Tamilnadu and IMA Ramnath branch, and special thanks to Dr. Anand for inviting me to give this lecture. I bring greetings from my hospital, Meenakshi Mission Hospital, and I have nothing to disclose. I have modeled my talk on the following headings, like I'll be giving a small introduction on the present scenario of cancer in our day-to-day practice, how to evaluate, how to go about the diagnosis and staging, and the role of general practitioners in deciding the treatments, and a small bit about prevention. So we all know that cancer involves almost every part of the body, and it is completely curable if we detect it early. This is the main gist of my talk. So a small information about the present statistics. The cancer at present is the second leading cause of death, and it is progressing upwards. The first cause of death of all causes of death put together is the cardiovascular disease, and cancer is catching up. This is the data from 1990 to 2009. We can see it is slowly rising. In India, where we stand at present, in the world, cancer is at somewhere around 18 to 19 million incidents in the males, and 8 million in the females is the mortality rate, 8 to 9 million in the males and females. In India, it is slowly rising, it is catching up. Another interesting data is that compared to the Western population, where there is an expected 42% rise over the next 20 years, we Indians in LDA and MDA countries, medium HDA countries, we expect it to rise almost 100%. So the number of cases we are going to see is going to double over the next 20 years. Another statistics from India, this is the present number of cases according to the 22 data, 2022. The number of new cases we have seen is almost 14 million, and then the death is almost 32. Death is almost 9 million. The number of new cases, this is another statistics from India alone. Number of new cases is almost 6 lakhs in close to 7 lakhs in males, and 7 lakhs in females. Totally 14 lakhs. We have an incidence of the new cases, and the mortality at present is almost 5 lakhs in males and 5 lakhs, close to 5 lakhs in females. So totally 10 lakhs patients are expected to die, have died in 22. So the number of new cases, we know that is going to rise. So what is the pattern of the new cases in males and females? In males, we expect that lip and oral cavity is going to be the number one in Indian population, followed closely by lung and esophagus and colorectal cancers. In women, breast and gynec cancers from the number 1 and number 2, followed closely by the lip and oral cavity and colorectal. There is a sharp change in the incidence of new cancers in the organ wise. Compared to the 2004, we see in women as a whole, in all the Indian cancer patients, cervix in women was the number 1 cancer, but in the recent data shows that cervical cancer has fallen down in number, but the number 1 place has now been replaced by lung. So as the new cancers occur, there is a change in the organs involved. So breast occupies the 2nd place in the cancers which affect the Indian population, but lip and oral cavity closely follows. So my talk will be mostly related to the most frequent cancers which will be seen by us in a day-to-day practice, mainly breast, head and neck, and lung. So coming to evaluation, I want to highlight this one thing. The WHO and the American Cancer Society has put upon these 7 early warning signs of cancer. I request everybody to please check for all the patients who visit their OP of these early warning signs. It can be easily remembered by that mnemonic or an acronym like caution. There's a change in bowel and bladder habits, a sore that does not heal, unusual bleeding or a discharge from any place, be it a postmenopausal bleeding, be it a bleeding from nose, bleeding from the gums, any ulcers which bleed, and presence of or new occurrence of a lump in breast or any other parts of the body, any new occurrence of indigestion or any difficulty in swallowing, any obvious change in existing wart or mole. Previously, mole which has been static for so many years, if there is any change in the size, shape, color, that has to be a warning sign. And any persistent or a nagging cough or hoarseness of voice is considered as an early warning sign of cancer. Most of the time, the symptoms of cancers are very, very vague. And if there is any obvious systemic symptoms, it means that we are dealing with something advanced. So most of the time, patient present with a weight loss or a vague systemic symptoms or loss of appetite, then probably we might be dealing with an advanced stage of cancer. Most of the time, the early cancers do not cause any symptoms unless it is affecting a critical structure. And usually we have to do a complete physical examination of these patients to find out the disease extent as well as the spread of the cancer. So how to diagnose? Three things are essential for proper management of cancer. One is the pathological diagnosis. Pathological proof is very much essential. We have to know the subtype also decide on the treatment of the patient. So without a biopsy, we cannot proceed further. The second important thing we want to know is the local extent of the disease. So for that, we may have to do a imaging. And also the third important thing is whether the disease has spread outside the area from where it has started. So these are the three essential things which we have to do for all patients we are diagnosing with cancer. So we have to prove the type of cancer. Biopsy is the first step, followed by a local imaging, followed by a metastatic imaging. So how to go about this? The very, very basic investigation which we recommend is an FNAC. If you see any lump, please start with an FNAC. FNAC is harmless, easily done OP procedure, relatively painless, and there is no chance of any needle track seeding. So this has been documented. You don't have to worry whether if putting a needle in the tumor or lump may cause it to spread. No, it will not. So FNAC is an office procedure. We can do for any and all lumps as an initial investigation. If you have the option to do a true cut biopsy, then it is actually much better than an FNAC. A caution about role of incision biopsy. Incision biopsy is not a recommended initial biopsy procedure. This we usually recommend if we cannot get an adequate tissue through core needle. So the incision has to be properly placed. It is usually should be ideally done by the operating surgeon because the placement of scar will dictate the further management. If the scar is wrongly placed, then we have to do additional modification of the surgical scar placement to include the existing scar. So ideally it should be done by the same surgeon. The placement of scar is very crucial. Usually in the limbs, it will be placed in longitudinally. In the breast, sometimes we see oblique scars, which we do not recommend. Excision biopsy is not the first option. Please do not rush to remove any lump in the breast or any lymph nodes which we see. So excision, not the first option. Only when we have exhausted all the available options to prove the pathology, then as a final option, we can do an excision biopsy to prove the pathology. It is ideally to be planned by the operating surgeon or the oncologist, and the placement of inappropriate scar should be avoided. This is one such case where an obliquely placed scar is done to prove the pathology as an initial diagnostic procedure. So this will lead difficulty in planning further treatment because we have planned a breast conserving surgery for this patient. I will explain how we went about that later. So if there is an ulcer or a growth, then we recommend doing an edge biopsy of the ulcer along with the normal tissue. And if it's a proliferative growth, a punch biopsy is equally sufficient. So the next step is how to stage the disease and to assess the local spread. So there are a lot of imaging options available. So which one should we go first? So CECT is adequate for most cases for local staging, except if you want to do any soft tissue delineation of the local part, like for a oropharynx, for a base of tongue, or for soft tissue tumors arising in the extremities, Most of the time, a CECT alone is sufficient. MRI is recommended only for soft tissue delineation. Most of the time, we see MRI abdomen pelvis for assessing staging of the patients. That is not the first line of investigation which we are looking at. CECT done in a proper 16 helical or 8 helical setup itself is fine. And PET-CT is nowadays become so rampant that for even early cases also we get patients coming with the PET-CT report. We do not ideally recommend a PET-CT to be done for early cases because it will complicate because like we get some nodes in the mediastinum for a tumor in the abdomen. That node may be an infective node or probably a tuberculosis node. That PET will confuse us. Then we have to chase about for the to prove the pathology of the node. So that may become unnecessary. For a locally advanced as a late cancers, PET is recommended, but for early case, we do not recommend a PET-CT to be done as an initial investigation of choice. Coming to the staging, the standard staging has not changed, but we use the same TNM, but there are a lot of additions to the TNM. This is one TNM staging which we use for breast cancer. To in the initial look, it may look confusing with lot of 1, 2, 3, 1A, 1B, 1C. With the addition of IGC markers, it has become still more confusing. This is just breast cancer staging according to the latest AJCC. This is very, very confusing for a general practitioner. I just try to simplify this. We don't have to bother about all these things. For a general practitioner, there are only 4 stages to remember. Stage 1, stage 2, stage 3, stage 4. Stage 1 is a small tumor. Stage 2 is slightly bigger tumor, but it is localized to the site of origin alone. Stage 3, if it has gone to the lymph node, irrespective of the site of the primary tumor, it is stage 3. And stage 4 is the metastatic disease. So if we can just remember these 4 stages, it will be easy to further investigate the patient. For an early stage, we don't have to do an extensive investigation. But even if a tumor is small, but with big nodes in the neck or big nodes in the axis,